Hello everyone, how are you doing? So, good morning or good evening, depending on which region you are watching me from. My name is Karim. I scored 279 on my step 2 exam and I am the head tutor at thematchguy. Welcome everyone to probably, or I'm confident it would be the best webinar you will watch for nutrition section. Hopefully after this webinar, there will be literally no problem at all that you will face on the nutrition section, and I will try to address everything about it. We'll go through the most high yield stuff on the nutrition part. So we'll start with the general nutrition, then we will go through the vitamins, then minerals. So we will not leave anything without it being discussed. And guys, I understand that you may sometimes need more understanding of this topic or any other topic, and that's why we will have our 7-day USMLE crash course. It usually goes through all of these systems, but this one will just be a sample for the nutrition only. We will not, of course, have the time to go through the other systems. After this, we will also try to practice few questions from our QBank Synapse, and we will see how it goes. Okay? Thank you, Carolina. And as we will do, guys, on the crash course, what I wanted you to do here is that I want you, as we go through the questions with each other, that you try to answer these questions. And the reason behind trying to answer these questions, because I want you to try to be familiar with these concepts, even if they are correct or incorrect. And again, I believe the reason behind it is that when your brain get a question incorrect, it will remember it more. And even if the brain got it right, it will also remember it more because it's a form of active recall. So the way we will do this crash course is that it would be as a question and an answer choice. After I go through the question, I will go through the explanations and the answer choices and how they can ask it on the exam itself. And after we will do this with each others, we will explain the whole concepts. So hopefully we will not leave anything without it being addressed. Okay? So let's just get started, guys. Sounds good. I believe they will start emphasizing more on the nutrition system, Kahla. And when we talk about nutrition system, guys, it's not like something new. I believe 70% of the nutrition system is from the metabolism and the biochemistry, right? For example, the vitamins. But what we'll try to do is that now we will go through it in more of details, high yield stuff, what they can ask about it. So we will not just go through, oh, niacin. Niacin will cause diarrhea, dementia, dermatitis. That's not how we will do it. We'll discuss niacin, how can it cause pellagra. Then we will discuss what are the ways we can get niacin deficiency. Then we will also discuss niacin toxicity, the side effects of it, how could you treat it. So we will not discuss it in very like superficial way like we used to do in the biochemistry itself. Okay, guys? So let's just get started. I believe you can see my screen, guys. You can hear me very well. I can also see the chat right now. Okay. Thank you, Ola. I'm glad you watched my cardiology on the crash course and you found it helpful. Hopefully, like you will see the other systems and you will find them amazing too. Thank you so much. Now, let's start, guys. So let's go with this one. We'll start with the general nutrition. Okay, Maria? So the first question is saying a 6-year-old boy with cystic fibrosis has poor weight gain, abdominal distension, and foul smelling flattering stools. Which enzyme deficiency most directly explains his fat malabsorption? What do you guys think here? Amazing, Nathania. Good, Maria. Amazing, Tasneem, Kara. Very good, Sharanya. Very good, Huzaifa. Amazing, Kahla. Amazing, guys. So let me explain this part for you. Okay. First, this person is having cystic fibrosis. Not all of the time they will mention that a person is having cystic fibrosis on the exam. But do you know how I know a person is having cystic fibrosis on the exam? They will tell me they are having foul smelling diarrhea and the recurrent upper respiratory tract infection. Once I see a child with foul smelling diarrhea and the recurrent upper respiratory tract infection, I always think about cystic fibrosis. Now, the problem with cystic fibrosis, guys, is that the mucus itself is very thick. Okay, you have problem on the chloride channel and the mucus is very thick. And this can affect mainly two organs that I need you to be aware of. The first organ it affects is usually the lung and the upper respiratory tract. And that's why the person will start to have recurrent upper respiratory tract infection and bronchiectasis. But the second organ, which is more very high yield, so see, is that it would affect the pancreas. And this will cause chronic pancreatitis. Okay? And what I need you to know, guys, about the pancreas is that the pancreas itself is important to absorb three important nutrients. It absorbs fat, and the way it absorbs fat is by lipase. Then it also absorbs protein, and the way it absorbs protein is by trypsin itself. And the last thing is that it absorbs carbohydrates. And the way it absorbs carbohydrates is by a specific enzyme called amylase. Okay, guys? So fat by lipase, protein by trypsin, and the carbohydrates by amylase. And in each one of those, there is three high-yield questions they will ask about. The first question about lipase. They will not ask about that it causes fat malabsorption, but they will ask about which vitamins will be deficient if you have problem in lipase. And these are the fat-soluble vitamins, right? A, D, E, K. Yes. And they sometimes can describe one of these vitamins to you, so you know that they are talking about the fat-soluble vitamins itself. A, D, E, K. The second question, trypsin. They will ask you, how does trypsin, or like, how can you get acute pancreatitis? The way you will get acute pancreatitis is by activating trypsin. And isn't trypsin important to digest protein? It will start to digest the pancreas itself, and that will start to damage the pancreas, and this can cause pancreatitis. So activation of trypsin itself and also an enzyme called enteropeptidase sometimes can cause pancreatitis. You will activate trypsinogen to trypsin, and this can cause pancreatitis itself. Okay. The last question about amylase. So we said amylase is important to absorb carbohydrates. But they will ask you, if you see increased amylase, does it only mean pancreatitis? Or there is other organ that can also secrete amylase? What do you think, guys? What other organ can secrete amylase? Or where would we get amylase secreted from? Amazing. Perfect. Perfect, Rosé. Perfect, Kahla. This would be, guys, usually from the salivary gland itself, especially the parotid gland. So if you have parotid gland inflammation or pancreatitis, either parotitis or pancreatitis, you can get increase in amylase. And do you know which virus can cause pancreatitis and can also cause parotitis? So it's a very high yield because this virus can increase amylase by two ways. Huh? Which virus? This virus we prevented by live attenuated vaccine called MMR. Amazing, guys. Perfect. Mumps virus. That's pretty important. Why? Because if you get mumps virus, you can get parotitis, pancreatitis, and orchitis, inflammation of the testicles. And the reason that's important, because I don't want you to say, oh, there is increased amylase, then the person have pancreatitis. No. Increased amylase can either be pancreatitis or parotitis, and both of them can be caused by mumps. If you need to search for pancreatitis only, then you measure the level of lipase. Lipase is more specific for pancreatitis only, but amylase can be increased in orchitis. So that's the three important things they will ask about on the pancreatic secretions itself, guys. Lipase, fat, ADEK, trypsin, pancreatitis, and then amylase will be increased in both the carotid gland and the pancreas itself. And the mumps virus can cause this. Okay, so that's very important. Now, another important thing that I want you to know, guys, okay, is that how can we absorb fat in general? That's a very important question. Because whenever I see a person with foul-smelling diarrhea or floating stools, I need to think about fat malabsorption. But I want you to see and to know how can we absorb fat. So we can absorb fat by the help of three organs. That's very important. The first organ we already talked about, which is the pancreas itself, pancreatic lipase. The second organ is the bile duct, because we need the bile itself to form something called the mesols to absorb fat. Okay? So if you have gallstones, for example, wouldn't you get fat malabsorption sometimes? Wouldn't you also get right upper quadrant pain after fatty meals? So not only the pancreas can cause fatty diarrhea and fat malabsorption, but problems in the bile duct because you need the bile to absorb fat. The third organ that you need, of course, it makes sense, is the GI epithelium. So, for example, do you know what infection? It's a specific protozoa that can affect the GIT epithelium and can cause offensive diarrhea. Huh. This infection can happen in people with IgA deficiency. What do you think, guys? People with IgA deficiency. Amazing. Perfect, guys. Perfect. Usually, Giardia itself. Okay? Usually, Giardia itself. Giardia, guys, can be very important to absorb fat. Okay? And it's usually, sorry, it can affect the GI epithelium, which is very important to absorb fat. So if you get a Giardia infection, you can get fat malabsorption. Now, the second cause of fat malabsorption. What disease, guys, whenever you see iron deficiency anemia and the fatty diarrhea, you need to think about it. It usually causes iron deficiency anemia because it affects the duodenum. And we know that iron is absorbed in the duodenum. So which disease affects the duodenum? It can cause atrophic villi, villus atrophy. And usually it can cause iron deficiency anemia. And because it affects the duodenum, you can't absorb fat. So you will also get fat malabsorption. Celiac disease. Amazing, guys. Perfect, Rosé. Perfect, Shania. So four important concepts. If you get chronic pancreatitis, you can get fat malabsorption. The most common cause is alcoholic, but take care of cystic fibrosis. If you get bile duct problems, you can get fat malabsorption. The most probable cause is bile stones. If you get affection of the GI, either infection by Giardia itself, this happens more commonly in people with IgA deficiency, or celiac disease, which affects the duodenum, so it will cause iron deficiency anemia, and it will also cause fat malabsorption. All of this can cause fat malabsorption. All of this will cause fatty diarrhea, and they will always ask you about the fat-soluble vitamins, which are ADEK. Okay, guys? Now, a very important thing. So here I saw a question, okay, asking about Anoche is asking why not Cryptosporidium? Why Giardia? So Cryptosporidium is also protozoa, and it's usually this protozoa is acid fast stain, but this protozoa cause watery diarrhea in HIV people. Anoche, watery diarrhea in HIV people. Yes, it doesn't cause fatty diarrhea. Okay, so that's pretty important, guys. Now. There was also another question about if we are getting this PDF, so you can get the PDF, guys. Usually, I will upload this recording on YouTube, and we will also post the link for the PDF itself on the YouTube channel within 24 hours. Okay, so that's pretty important. Now, we also said carbohydrates absorbed by amylase, but take care the pancreatic and the salivary duct itself. And take care, sometimes the lactose is another enzyme that's very important. It's found in the brush borders of the GI, and it's usually used to absorb lactate, which is usually the disaccharides that's found on milk, and we will talk about it in details in the next questions. Okay. Yes, always when you see fatty diarrhea in a traveler, for example, they will tell you traveler person. Think about Giardia infection, or if they tell you IgA deficient people, always think about Giardia infection. Okay, Amna? Now, let's go through this question here. A severe burn ICU patient receives adequate calories but low protein. After 5 days, he has significant muscle wasting despite stable weight. What metabolic state best describes this? Is it positive energy balance, positive nitrogen balance? Is it positive energy balance, negative nitrogen balance? Is it negative and positive? Or what do you think here? Amazing, Rabab. Amazing, Kara. Amazing, Sindhu. Doniz, welcome. And it's always nice to see you, Doniz. So, very good, Doniz. Very good, Rama. Good, Albert. So, for this one, guys, Okay. We have two important concepts that I need you to know on the nutrition. We didn't care about it before because we had only biochemistry, but now they're important. Okay. The first concept is when we talk about energy balance. Energy balance means how many calories you are taking. Okay. And there is positive and a negative. And what I want you to know is that if you are taking adequate calories, that's a positive energy balance. If you are not taking adequate calories, that's negative energy balance. So this person here that has severe burn is taking adequate calories. So he will have positive energy balance. Now, the second thing is nitrogen balance. Where do we get nitrogen, guys? Do you remember nitrogen NH3? Where do we get NH3 itself? There is a specific nutrients that give us NH3 and also give us glutamic acid. What do you think? Amazing. Amazing Cordero, amazing Nazareth. Proteins, guys. Now let me tell you something. Burn patients will always lose protein, no matter what. So they will always have muscle wasting and they will lose too much protein. And that's why they will have negative nitrogen balance. So here the answer would be positive energy balance and negative nitrogen balance. That's very important, guys. Okay, that's very important. Now, another question that they ask. A severely underweight child has profound muscle wasting, but no edema. Another child of similar age has edema and fatty liver despite adequate caloric intake. What distinguishes between these people, and what do you think is the diagnosis we are talking about? Like, what are these two diagnoses, guys? Amazing. Amazing, Albert. Amazing, Daniela. Very good, Harry. Good, Carl. Amazing. How are you doing, Carl? It's always nice to see you. Amazing, guys. Perfect. So for this one, guys, okay, whenever I see a person that's having like underweight or whatever, and they are having malnutrition, there is always two diseases I want you to know. Yes, the first disease is called what? Kwashiorkor. And the other disease is called the marasmus. Okay. Now, what I want you to know that marasmus itself, guys, is usually deficiency in protein only. Sorry, kwashiorkor is deficiency in protein only. And it will usually cause edema and ascites, or it's similar to ascites. And the reason behind this, because if you lose protein, you will have decreased oncotic pressure. And then this can cause edema. Remember, guys, if that's the blood vessel here, and that's the tissue, usually the proteins make something called oncotic pressure. And this oncotic pressure is like a sponge. They absorb water, okay, from the tissue to the blood vessels. If you don't have protein, for example, you have kwashiorkor disease, what will happen? What will happen is that now you don't have this oncotic pressure that absorb water from the tissue. So now water will go into the tissue, and now you will have edema, guys. Okay? So kwashiorkor itself will cause edema. Marasmus is deficiency of all nutrients, not only protein. So you will have deficiency in protein, carbohydrates, and the fat, and the marasmus doesn't have edema. So how would you differentiate kwashiorkor from the marasmus itself from the edema itself? Kwashiorkor will cause edema, marasmus will not. So here, for example, this one is kwashiorkor, guys, okay? Because they are having edema, as you can see. On the other hand, marasmus is problem in everything, and it doesn't cause edema at all, okay? So that's pretty important, okay? Now, for very important Carolina here, I will repeat this one. Nitrogen balance, guys, means protein. In burn people, they have protein deficiency, and that's why they will have negative nitrogen balance. So nitrogen balance is a protein. Burn people, they have protein deficiency, guys. So they will get negative nitrogen balance. Okay. Now, so take care about kwashiorkor and the marasmus. They can ask about which one is protein, kwashiorkor. Which one is total caloric deficiency? This would be marasmus. Okay. And usually we see them most commonly in immigrants. Okay. Now, let's get into this very important question. A 52-year-old man is brought to the emergency department because of progressive weakness and confusion. Okay. Now, he has a long history of alcohol disorder and was recently hospitalized for severe malnutrition. 2 days after initiating nutritional support, he develops worsening dyspnea and generalized muscle weakness. Okay. Laboratory studies are most likely to show which of the following patterns. What do you guys think here? Amazing, Brody. Very good. Amazing, Sunzo. Very good, Sosi. Very good, Nelsa. Amazing, Ishwarya. So for this one, guys, that's very important. Okay, that's very important. If you see a person coming to you in the emergency and you're hospitalized, and now they are initiating nutritional support. Now, they told you there is a history of alcohol. So let me tell you something, guys. Okay, if you are alcoholic, for example, okay, or you are being hospitalized, usually when you are very hospitalized and you are alcoholic, for example, you will have decreased glucose. Okay. Now, how would you treat the decreased glucose? As any physician will do, the physician will give glucose, right? It makes sense. Now, when you give glucose to a person that's alcoholic, okay, what will happen to the insulin level? The insulin level will increase, right? When you give glucose, insulin increase. Now, once the function of insulin, guys, first it will get glucose in, but it also gets three important electrolytes inside the cell. Usually these electrolytes are the electrolytes that are originally found inside the cells. It will get potassium inside the cell. It will also get phosphorus inside the cell, and it will get magnesium inside the cells. Okay, so usually insulin will move potassium, phosphorus, magnesium from the blood vessel to the cell itself. Okay, and if you do this, what will happen to the blood vessel potassium and phosphorus and magnesium? They will decrease because you are shifting them from the blood vessels to the cells itself, to the tissue cells, and this will decrease them. And we call this condition refeeding syndrome. This is especially important and very common in alcoholic patients because alcoholic patients already have decreased magnesium. They already have decreased phosphorus. They already have decreased potassium. So if you give them glucose and you increase the insulin level and the insulin pushes the remaining potassium, the remaining phosphorus, the remaining magnesium inside the cells, and they have nothing at all in the blood vessels, they will have decreased very much hypomagnesemia, hypokalemia, and hypophosphatemia. And the reason we call it refeeding because you are refeeding a person that's starving, but you did it wrong. Do you know how should we get it right to prevent refeeding syndrome? First, you will give them the glucose as you do, okay? But you should give them the electrolytes, phosphorus, potassium, magnesium, and you should always also give them thiamine or vitamin B1. That's very important, especially more important in alcoholics. And we will talk about the reason behind it. But usually also if you give an alcoholic glucose, they will also have thiamine deficiency, guys. That's another thing that they will have, or vitamin B1 deficiency. And this can cause few things called Wernicke-Korsakoff and beriberi. Okay, so here they will have decreased phosphorus, decreased potassium, decreased magnesium, and also decreased the B1 or thiamine. That's if you want to add it. Okay, now here. Okay, so here the diagnosis is refeeding syndrome, guys. Okay, and the reason behind it is that insulin will surge after you give them glucose. And this will deplete phosphorus, potassium, and the magnesium because it will drive them inside the cell. I also need you to know that you need to give thiamine before refeeding, and this will prevent all these complications here. Okay, so that's pretty important, guys. That's the question itself, Megdas. Again, you will have access to the PowerPoint in the YouTube channel. Okay, okay. I'm just trying to go into a normal rhythm so you guys don't get bored out of me, and at the same time I can explain the concepts with you. Okay. Now let's go through this question with each other. So a patient on total parenteral nutrition for 2 weeks after bowel surgery, he develops um, increased alkaline phosphatase and elevated AST/ALT. There is also gallbladder sludge, meaning the gallbladder is not moving, and fatty liver on ultrasound. What's the mechanism here, guys? What do you think in this one? Very good, Brody. Amazing, Rodania. Amazing, Sharanya. Good, Bartov. Good, guys. Perfect. Good, Maria. Good, Mihak. So here, Dionysus, this person is having what? They are having decreased like nutrients, and they have been taking total parenteral nutrition. Okay. Now I will tell you something, guys. Do you remember what's the importance of the biliary duct? The biliary duct we said, and the gallbladder secrete bile. And do you know what nutrient we said bile is important to absorb? What do you think, guys? Fat itself. Amazing, Nathani. Amazing, guys. Bile absorb fat dynease. Okay. Now here is the thing. Here is the thing. If you are taking total parenteral nutrition, look at me. Do you know what is total parenteral nutrition? You give the fat and you give the carbohydrate and you give the protein. You give the whole nutrition inside the veins. Okay, you give it in the blood vessels itself. You don't give it in the stomach. So if you don't give food in the stomach, what will happen to the bile duct? Huh? Yes, the bile duct itself will not move. Okay? And the reason it will not move because you don't have food in the stomach. Usually when you get food in the stomach, guys, like fat, you will secrete an enzyme called cholecystokinin. And this enzyme from the name, chole means the common bile duct. Cyst means the gallbladder. Gallbladder means cyst. Kinin, kinetic means movement. So this enzyme is important for the movement of the gallbladder and to move bile once you have fat in order to absorb fat. So if you don't take any fat because you are doing total parenteral nutrition, then do you need to absorb and to secrete bile in the stomach? You don't, right? So you will have bile accumulating in the common bile duct because it's not secreted. And this will cause something called biliary stasis. Stasis meaning the bile itself accumulates. And when this happens, this can cause gallstones. So the answer here is decreased cholecystokinin, guys, because you are not taking fat. So there is no point of secreting cholecystokinin to secrete bile. You don't have fat to absorb, right? And this will cause the bile itself to accumulate on the gallbladder. This will cause something called the biliary stasis and the gallstones and the gallbladder sludge. Now, why they have increased alk phosphate? Because this is usually increased when you have gallbladder problem and also if you have bone problems. So here, because you have gallbladder and bile duct problems, you will have increased in alkaline phosphatase. Okay, guys? Now the question they ask, what's the most common complication of total parenteral nutrition? The answer is bile duct stone. Bile duct stone. Okay. Now there is another question. What's the most dangerous, not common, complication of total parenteral nutrition? And the answer, guys, is what amazing, Sosi. Septic shock. Septic shock. People taking total parenteral nutrition, guys, will develop septic shock. Okay? Because imagine literally you are giving food, which sometimes can be contaminated inside the blood vessels. And you already are very weakened because people that are total parenteral nutrition, they are in the emergency department. They are in the ICU. So if you take total parenteral nutrition, you will have an increased risk of septic shock. So the most common complication is gallstones. The most dangerous is septic shock. Okay? And in this webinar, guys, I don't want you to memorize. Memorizations usually come later when you answer Anki cards, do questions, or watch the session for the second time. Here, I want you to understand these things. Okay? Now, because if you try to understand and memorize at the same time, you will find yourself very overwhelming with it. Very overwhelmed with it. Okay. Thank you so much, Dainis. Appreciate it. Now, let's go through the other ones. Okay. Secretine itself. What's the importance of secretine, guys? From the name, secretine, okay, usually people will say, oh, it will cause pancreatic hypersecretion from the name. But here is the thing. Sometimes the name tricks us. It's called secretine, but it decreases hydrochloride. It decreases HCl, and it decreases gastrin secretion. So secretine, guys, decrease gastrin secretion. Okay. But how about gastrin itself? Gastrin itself is important to increase the hydrochloride and to increase HCl secretion. Okay, so secretine decrease HCl secretion, but gastrin increase HCl secretion. Now, how do I remember it? Remember gastrin. So it's important to secrete the gastric acid itself. Okay. Yes, secretine also decrease bicarb. I remember secretine decrease lots of things. Amazing, David. Now I will ask you a question. If we know gastrin, okay, is important, increase bicarb. It's important to secrete HCl, which is the gastric acid. Then we know that we can get a disease that's called gastrinoma. And in this disease, you have too much gastric acid, so you will have too much ulcers. And this disease is called Zollinger-Ellison syndrome, and it's usually part of MEN1. MEN1. Okay? So the only thing I want you to know is that too much gastrin can cause peptic ulcer, and this is a disease called the Zollinger-Ellison syndrome, which is MEN1. Now, how about somatostatin? The way I want you to remember somatostatin is that it usually decreases the other enzymes. So, for example, if you have too much gastrin, somatostatin will decrease it. If you have too much glucagon, somatostatin will decrease it. Okay? And as Maria said, it's called somatostopin or somatostopin because it decreases everything. So if you know it decreases everything, then this is the drug of choice if you have any tumor in the pancreas and you need to decrease the enzyme associated with this tumor. And the treatment itself is called octreotide. Octreotide is a somatostatin analog. We use it to treat any pancreatic disorders, okay, on any pancreatic tumors that have too much secretions. So somatostatin stop everything, okay. So yes, anything, but you can use it to treat viboma, glucanoma, gastrinoma, right? Acromegaly because it stops the growth hormone itself. Amazing, amazing, guys. So that's for somatostatin itself, okay. So here, to go back to this one, the answer is decreased cholecystokinin. Why? Because this person doesn't have enteral feeding. He is not feeding through his stomach. So he is not secreting cholecystokinin. Okay? And now they are having steatosis and decreased gallbladder contraction and the bile stasis, and this will cause gallstones. Gallstones. Okay? Now, let's go into the next question. Okay? Now, a 38-year-old woman comes to the clinic because of recurrent episodes of nausea, abdominal cramping, diarrhea, sweating, and also palpitation. That's shortly after meals. She underwent sleeve gastrectomy 6 months ago for obesity. The symptoms usually begin 15 minutes after eating desserts or sweetens. She denies fever, blood in stools, or recent travel. Which of the following best explains the symptoms? That's the first time I explain this disease for step 1. Because most of the time I go for this disease for step 2 and step 3, guys. But because the nutrition, this disease is very important now for step 1 also. Amazing Rama. Amazing Marina. Very good Anuj. Very good Ishwari. Amazing. Amazing Dainese. Good. Good. So for this one, guys, the answer would be D. And this is called dumping syndrome. I will explain it to you in a very easy way. Okay? Now look at the slide, guys. Usually, you have the stomach, right? And after the stomach, you have the duodenum. So stomach is in duodenum. And usually when you eat something, doesn't it stay in the stomach? and then the stomach starts to send it to the duodenum one by one. Okay. Now, dumping syndrome happens when a person get gastrectomy, meaning he undergo an operation to remove the stomach. So imagine you remove the stomach, guys, and then you connect the esophagus with the duodenum. Do you know what will happen? What will happen is that you will eat food, right? And instead of this food going to the stomach and stay in the stomach and then send it to the duodenum one by one, what will happen is that all this food will dump. That's why it's called dumping in the duodenum. And when the food dump in the duodenum will be surprised. There is too many food. Do you know what will happen? You will start to panic. The duodenum will literally panic and will activate the sympathetic nervous system. This will cause palpitation, headache, and all of these symptoms, the sweating, okay, and diarrhea. Another thing is that you will dump all this food. So what will happen to the insulin level, guys? What do you think? If you dump all this food, too much glucose dumping, what will happen to the insulin itself? It, as a reaction to the too much glucose you are dumping, so say. Remember, have you ever taken a large meal, guys, like pizza, for example? Do you know what will happen if you take a pizza? What will happen is that you will eat too much glucose. Yes, Marie. Yes, guys. Then insulin will increase too much. And when insulin increase too much, it will decrease glucose again. And this will cause severe hypoglycemia. And that's called like after crash, right? Sometimes we don't recommend the people to take too much glucose because too much glucose will secrete too much insulin. This will cause hypoglycemia. Okay. And that's what also happen in dumping. They will get hypoglycemia. And do you know what's the hypoglycemic episodes? They will start to have sweating and the palpitation, right? And all of this. And that's what's dumping syndrome, guys. Dumping syndrome, you dump too much food into the duodenum because your stomach is not working. So this will cause increase in the sympathetic activation. This will cause diarrhea, sweating, palpitation, and also increase in insulin and cause hypoglycemia and hypoglycemic episodes. This only happen after gastrectomy, like Roux-en-Y gastrectomy, for example. Okay, that's true, Raj. Usually, what happens after eating pizza is happiness. Uh, I did it yesterday. I ate pizza because Friday is my day off, and what happened is that I felt like I was very bloated and I was very happy. But then reality check happened after 30 minutes. I went into a ride and then I got hypoglycemic episodes. Okay. So yeah. Now here, that's that's a dumping syndrome. 10 to 30 minutes after eating. Okay. You eat large sugary meal, pizza. Then what will happen is rapid gastric emptying. You empty very fast, okay, into the small intestine. This will cause too much like food to go into the small intestine. This will cause activation of the sympathetic and the vasomotor symptoms. Okay, like diaphoresis, flushing, tachycardia, palpitation. Okay. Now, why does it cause diarrhea? Imagine you have too much sugar into your intestine. Wouldn't this sugar have high osmolarity, so it will absorb water, and that's why you get diarrhea? Okay, from the hyperosmolarity that absorb water. Okay, now how would you manage it? Do not eat pizza. Eat frequent meals. Okay, avoid simple sugars. Increase protein. Okay, all of this. So here, post gastrectomy, you will have dumping syndrome. Now, what can also happen after gastrectomy? After gastrectomy, now you don't have a stomach to secrete HCl, right? You also don't have a stomach to secrete intrinsic factor. HCl is important to absorb iron, so you will have iron deficiency. Yes, I know, iron is absorbed in the duodenum, right? But you still need HCl from the stomach to absorb it in the duodenum, okay? HCl and the intrinsic factor is important to absorb B12. And I still know B12 is absorbed in the terminal ileum, but you need intrinsic factor and HCl from the stomach itself to absorb it. Okay, so that's very important. Yes, from parietal cells. These are the cells that secrete intrinsic factor and HCl. Amazing, Kevin. Okay. Also, after gastrectomy, you will get calcium and the vitamin D deficiency sometimes. Okay, because vitamin D deficiency can easily happen. Okay, can easily happen. Okay, now, is it the same with band gastrectomy? A little bit the same, Rosé, but in band gastrectomy, we do partial gastrectomy. We remove part of the stomach. Yes, it's a better lipase activity, Raj. Yes. Um, but here, guys, that's very important, like to know these specific parts, okay, and to know the dumping syndrome, the iron and the B12, and why do we get them? We get them because we don't have HCl for the iron. We also don't have HCl and the intrinsic factor for B12, okay, because we don't have parietal cells, because parietal cells are in the stomach, okay. Now, let's go into this question, guys. A 6-year-old boy has chronic bloating and diarrhea that worsens with dairy. His mother had similar issues in childhood. What's the underlying cause for this? What do you think here, guys, in this one? Amazing to say. Amazing Salma. Amazing Rodina. Very good. Very good, Rama. Perfect, guys. Perfect, Raj. Perfect, Salma. So here, guys, it will be what, Juan? Deficiency of lactase at the brush border. And I will tell you why. Okay. So we have few things I want you to know about the carbohydrates. Carbohydrate, guys, can be having multi-saccharides, meaning they have multiple sugars with each others. And that's usually starch. Starch is polysaccharides with each others. Okay. Now, another thing is that carbohydrates can be in bisaccharide or disaccharide. We can call it bi or disaccharide. And disaccharide, guys, is usually um, lactose or, for example, saccharose. I want you to know these two. Why do we call them disaccharides? Because you have two sugars on them. For example, lactose, guys, from the name, lactate, lactation, breast, right? So this one is the one that's found in the milk and the dairy products. And this one have two sugars. It have glucose and galactose from the name, galactose. So lactose is made from glucose and galactose. Okay. Now, how about saccharose? Saccharose from the name saccharide, that's usually the fruits. It's found in the fruits. That's saccharose. And usually saccharose is made of two sugars, also glucose, but fructose, not galactose. Fructose, fruits, fructose. So we have lactose and saccharose. Okay. Now, can your body absorb lactose, for example, right away? It can't. The body only can absorb one sugar at a time from the GI. So how you can divide this lactose into glucose and galactose? How you can break it down? Usually you break it down by a specific enzyme called lactase. When something is called ase, it means it break down. For example, when we said amylase, okay, it break down like the sugar itself. Lipase, it break down lipids. So when something is called ase, it means it break down. For example, do you know that all the lysosomal enzymes are called ase? Okay, and the reason they are called ase because they break down things. Okay, so most of the enzymes that break down stuff, we call them ase. So lactase here break down break down lactose into glucose and galactose. And now we can absorb glucose and we can absorb galactose and the person will not have a problem. Now, sometimes you can get lactase deficiency. And this can happen by two ways. Either primary, like it's a genetic problem, okay, or secondary. For example, you get gastroenteritis. And the gastroenteritis, for example, can damage the gastric or the stomach itself and the gastric lining. So gastroenteritis, so you will damage the brush borders, right, Rodina? Now, if you have this, what will happen? What will happen is that now you cannot break down lactose into glucose and galactose, right? And what will happen if you cannot break down lactose into glucose and galactose is that lactose will increase in the stomach and the intestine. And can you absorb lactose in the stomach and the intestine? You can't. So what's happening here? Do you know what's happening? The bacteria will be very happy because now the bacteria finally found a food to eat. They have lactose. You didn't absorb it. So the bacteria will ferment this lactose. It will secrete hydrogen. That's why it's a positive breath hydrogen test. And when it ferments the lactose, it will secrete too much gas. That's why the person will have bloating and diarrhea. Okay? The bacteria of the intestines in general. Okay? And that's why if you have lactase deficiency, you will have lactose free in the GI. The bacteria will ferment this lactose. You will start to have bloating and diarrhea. And this usually happens after dairy products. Okay? So deficiency of lactase at the brush border. Now I will go very fast through the other answers. Autoimmune destruction of intestinal villi, that's usually celiac disease, right? Celiac disease, perfect. Absence of pancreatic lipase, that's what you have in chronic pancreatitis, like cystic fibrosis. Defective chloride transport, also what? Cystic fibrosis. Okay? Impaired fructose metabolism in the hepatocytes, that's one disease we will talk about, which is fructosemia and all of this. We will talk about them. Okay? And the fructosuria also. So here it's decreased the brush border lactase. You will have bloating, flatulence, and watery diarrhea. And didn't we say the bacteria will secrete HCl and it will ferment the lactose? So you will have decreased the pH and that's very important, decrease the pH in the stool. And something called the positive reducing substance. What are reducing substance, guys? These are carbohydrates, like lactose, glucose, galactose. You will see in the stool, you have positive carbohydrates. Okay? Now, how can you get also lactate deficiency? You can get it after GI infections, like rotavirus, as believe Rodina said, and this can cause damage to the enterocytes, which are the cells in the GI, and this can cause lactase loss, but transient, reversible. It will resolve with time. Okay. What's the management? Very simple, lactose-free diet. And recently there is something called oral lactase enzymes. You give them lactase enzyme supplement. Okay. Now, pretty good. Now let's discuss the ones that I told you to know about, guys, here. A 7-month-old boy develops vomiting and lethargy after fruit juice. There is also honey that has been introduced. Now the person is having hepatomegaly, low glucose, and there is reducing substance in the urine. Which enzyme is deficient? What do you guys think here? Huh. Answer me anything. Is it fructokinase, galactokinase, aldolase beta, or galactose 1-phosphate transferase? That's also true, Brody. That's a good catch. Okay. Amazing. Perfect. Perfect, guys. Okay, perfect. So we have two problems, guys, in absorbing two important saccharides. Problem in absorbing galactose and the problems in absorbing fructose. The problems that happens in absorbing galactose, we call them galactosemia and the galactokinase deficiencies. These ones, A and C. The problems that happens in absorbing fructose, we call them fructokinase and aldolase B. Now I will tell you exactly how do you differentiate between them. Okay. First, how to know a person have galactose or galactokinase. I don't want you to differentiate between the two diseases now. I want you to know how to know a person have problem in galactose. You will know that a person have problem in galactose by two ways, Kara, right? The first thing is that it will happen at newborn because this is where you start lactating, right? It will happen at newborn before introducing solid food because this is galactose. Isn't galactose coming from lactose? So it happens from breastfeeding. So it happens at newborn, not 6 months old. Fructose, they happen after 6 months. Once you start introducing fruit, because we said fructose from fruits, right? So that's the first thing. The second thing is that if there is cataract or not. Cataract or not. Galactose will usually cause cataract because they will have increase in something called sorbitol. They will accumulate a specific substrate called sorbitol. This will deposit in the lens, and this can cause cataract, which is opacification of the lens. Fructokinase and aldolase B, they will not cause cataract. Okay, now let's go into the details about them. So how we differentiate between them in details. Okay, I want you to know this one. Okay, 1 second here. Let's start with galactose. Now let's agree on something. I don't care about which galactose is problematic. In general, both of them will cause cataract. Okay, so that's very important. Either classic galactosemia or galactokinase deficiency. This classic galactosemia or galactokinase. Both of them will cause cataract. Both of them will usually happen at infants before 6 months. Okay. Now, what would be the difference between them? Here is the thing. That's here, guys, how we can metabolize galactose. We first convert it into something called the galactose 1-phosphate, then into something called UDP galactose, then we will make glycogen out of it. Okay. Now, let me go with you through this enzyme. This enzyme here, I need you to understand it. This enzyme is called the galactokinase, and its function is to take 1-phosphate from ATP and to stick this phosphate into galactose. So it usually converts galactose into galactose 1-phosphate. Now, why do we do this? If you have galactose 1-phosphate, it's usually trapped inside the cell. So the way I think about phosphate is like a chain. We use it to trap galactose inside the cell. So for example, we will use it to trap it inside the liver in order to be able to use it. Okay. Now, why I am telling you this? Why are you bothering with me, Dr. Karim, about this information? Because in the first one, galactokinase, you have deficiency in galactokinase here. So did you even trap galactose? You didn't, right? So galactose will increase in the blood vessel. It will not increase in the liver. It will just cause cataract and that's it. Then most of it will go in the urine. So it will not cause symptoms at all. Just urine and like asymptomatic, because it will be secreted in the urine and the cataract. Why? Because it didn't accumulate inside the liver, for example. So it didn't cause jaundice or liver failure or anything like this. Because it's a problem in galactokinase. You didn't even phosphorylate it. Okay? So that's why galactokinase only cause cataract and that's it. And the galactose in the urine, galactosuria. And that's why we call galactokinase, as Nelsa said, kinase is the kinder one. Because it only causes cataract and that's it. Okay? Now, how about classic galactosemia? No, this one will cause cataract because you will have like accumulation of galactose, of course. But it will also cause increase in galactose 1-phosphate, the phosphorylated one. So this will cause more symptoms because it's already inside the liver. It will start to deposit in the liver and damage the liver. So it will cause vomiting, diarrhea, jaundice, all of this, failure to thrive, and all of this. Okay, guys? So kinase is the kinder because it didn't phosphorylate galactose yet. So it will go in the urine and it will cause cataract. That's it. Okay? But if you see cataract with other symptoms, that's the bad one. GALT. We call it classic galactosemia. Okay? Now the same for fructose. Fructose happens at 4 to 6 months once you start introducing person to fruit, and it usually causes no cataract at all. No cataract. Because it doesn't convert to sorbitol. It's already the product of sorbitol. It's not converted to sorbitol. So it doesn't cause cataract. Now, how do I differentiate? Fructokinase is problem here. So you will have accumulation of fructose. This will just go into the urine and cause fructosuria. And that's it. It doesn't even cause cataract. Okay? Now, on the other hand, aldolase B is the bad one. B is the bad one. Why? It will accumulate fructose 1-phosphate. This will accumulate in the liver. It will cause hypoglycemia, vomiting, liver failure, renal failure, and all of this. It will start to accumulate in the organs. Okay? So that's how I answer the question. First, is there cataract or not? If there is cataract, I know it's galactose. If there is no cataract, I know it's fructose. Then I ask myself, does the person have any symptoms or no symptoms? No symptoms, kinase, either fructo or galacto. There is symptoms, aldolase B. Symptoms with no cataract, aldolase B. Symptoms without cataract, GALT. So now, guys, we know how to memorize this and also how to understand it. Okay? So I don't want any like justification if you got it wrong on the exam, because you will get it like you will get 2 questions on it on the exam, probably. Okay? So that's all of what I explained here. So aldolase B, we talked about this and all of the onsets. I will just like send again the PowerPoint in order if you want to memorize it later on. Okay. Now let's go here, guys, in this one. Yes, Bruna. This one, branching enzyme. So branching enzyme is not important. It's a disease called Anderson, but it's not very important. It's like you cannot store glycogen. But there is a specific other enzyme called debranching. Okay. Debranching is important in a specific disease called what, guys? Corey. I will tell you about the other one, Andrea. Corey disease. Debranching enzyme is important for a specific disease called the Corey. This disease is like one of the glycogen storage diseases in the biochemistry. Now, Andrea said Burnet smell, which is very close, because Burnet sugar is usually a disease called what? Maple syrup. It's a problem in the branched chain amino acids. That's why she mentioned that. Branched chain amino acids. You can't break down branched chain amino acids, which are valine, leucine, and isoleucine. Okay, guys? But yeah, these are for biochemistry, yes. Okay. Now, we'll go here. Yes, I will try to send the PowerPoint in the YouTube with the annotation and without annotation. Okay. So let's see here, Bruna. Let's see here, Susie. A 6-year-old. So here, like, we'll start the vitamins, and while we start the vitamins, we'll go back into the other ones. Okay. I will post the YouTube channel link in. Also the WhatsApp channel, because we have created WhatsApp channel, guys. Okay. Again, before you, yeah, okay, let's answer this one. So we will now start the vitamins, guys. Okay. So a 6-year-old boy, okay, from a developing country has night blindness and frequent respiratory infections. Eye exam shows conjunctival spots with a foamy appearance. What's the diagnosis? Okay. Is it pseudotumor cerebri due to vitamin A toxicity? Is it pellagra due to niacin deficiency? Is it beriberi due to thiamine deficiency? Is it xerophthalmia due to vitamin A deficiency? What do you guys think here? Amazing. Amazing, Subiha. Good drama. Good Janani. Amazing, Rabab. Perfect, guys. Perfect, Imelda. How are you doing, Goda? How are you? I remember. I still remember most of you guys also, either from the previous cohorts or from the crash course. Good series. So let's start with this one, guys. Okay. A person come to you from a developing country. Okay. And he's having night blindness, frequent respiratory tract infections, okay, and conjunctival spots with a foamy appearance. Once you see night blindness, okay, or dry skin, or eye accumulation of foamy appearance, that's called the bitotic spots, I only need you to think about vitamin A deficiency, okay? Vitamin A deficiency, guys. So this person is having something called xerophthalmia. Zero means zero literally. It means there is no fluid in the eye. Sometimes it will cause like dry eye, okay? And usually like pitotic spots. And also night blindness, that's called noctylipia. And usually the reason behind this is vitamin A is important for night vision, okay? And what I want you to know about vitamin A is that please, please, please do not confuse vitamin A deficiency from vitamin A toxicity, guys. Okay. This person here, when you see night blindness and when you see dry skin, for example, think about vitamin A deficiency. Okay. On the other hand, if I tell you there is headache, vomiting, papilledema, I need you to think about vitamin A toxicity or something called what, guys? Pseudotumor cerebri, Niha. Pseudotumor cerebri. Karim, why they are calling it pseudotumor cerebri? Because it's similar to tumor. If you have a tumor in your brain, wouldn't you have increased intracranial pressure? Wouldn't you get vomiting from too much pressure, headache, because the pressure is usually pressuring in your meninges? You will also get papilledema on the eye because the pressure in the brain is pushing towards the eye. And that's why vitamin A toxicity causes pseudotumor cerebri, but deficiency causes xerophthalmia. Okay? Now, another thing I want you to know. A person is coming to you to the clinic and she wants you to prescribe her vitamin A for acne, but oral vitamin A, isotretinoin for acne. Okay? What should you do before prescribing her vitamin A? Very good. Amazing. Amazing, guys. So I always tell my students that there is two vitamins I want you to know. Vitamin A is teratogenic. It's contraindicated in pregnancy. And before giving it to a woman, you need to do double contraceptions to prevent pregnancy. Okay? And then I tell them vitamin B9 or folic acid is important for pregnancy because it's important for neural tube defects. Okay? So vitamin A is contraindicated, but folic acid is important. Okay? So here that's very important. You need to give two contraceptives to prevent a pregnancy. Amazing, Brunhild. And of course, you will do HCG testing. Now, extra thing I want you to know. Vitamin A is important in 3 diseases. We said acne. The other disease is an infection. Do you know which infection vitamin A is important on? It can cause cough, coryza, conjunctivitis, Daniela. Cough, coryza, conjunctivitis, and the Koblick spots. Koblick spots. It's also one of the live attenuated vaccine, MMR. We said the M for mumps. The other M is for what? Measles. Amazing, guys. Measles. The only treatment for measles is vitamin A. Okay? Now, vitamin A is also important for a specific leukemia that can have all rods. What leukemia have all rods, guys? Very good. Very good. It's important for acute premyelocytic leukemia. Very good. This leukemia is 15-17 translocation. It has all rods. You treat it with transretinoic acid. Because usually vitamin A help in maturing. It will mature the cells. Remember that AML is immature cells. So if it help mature it, it will prevent and it will treat AML. Okay? And it will also be important in measles and acne. That's how I remember vitamin A itself. The deficiency, the importance of it, the toxicity. So here's the deficiency, bite spots, it can cause this, and it can cause night blindness, okay? But vitamin A toxicity will cause the other way around. Remember, vitamin A is one of the fat-soluble vitamins. So if you have cystic fibrosis or bile duct problem or giardia or celiac disease, you will have vitamin A deficiency, okay? And that's here is vitamin A deficiency, guys. It can cause bite spots. That's white foamy spots, okay? It can cause dry skin, and it can cause some of the other stuff. Now, I wanted to ask you, vitamin A, where would it act? Would it act on the cell membrane or the nucleus or the cytoplasm? What do you think, guys? Go deep inside, Rosé. Isn't vitamin A fat-soluble vitamin? So it can what, Berkey? It will try to go through the cell membrane and it will act on the nucleus. Okay? It acts on the nucleus, guys. It's one of the fat-soluble vitamins. Isn't the cell membrane made of fat? So only fat-soluble vitamins can go through it. Okay? So fat-soluble vitamins will work on the nucleus. Now, What other hormones will work on the nucleus? Because students always ask me about this. Any hormone that's fat soluble, right? Steroids. So corticosteroids, okay, testosterone, androgen, estrogen, all of this, okay, are also fat soluble vitamins, sorry, fat soluble hormones, and they will work. Also thyroid. Now you will tell me, but Karim, isn't thyroid water soluble, not fat? Yes, but it has a carry protein, thyroglobulin. This carry protein, thyroglobulin, will make it cross the cell membrane. Okay, so thyroid, steroid, vitamin A. There is one additional thing, very important for nutrition. This thing, if it's deficient, it can cause problem in smelling, problem in tasting, rash in the mouth, rash in the genitalia. It's a specific mineral deficiency. Is it copper or zinc or chromium or what? Zinc. Zinc, guys. Zinc ado. Zinc bouquet. Amazing. Zinc deficiency, guys. That's the third important stuff. Okay? Usually zinc deficiency is very important and it work on the DNA in the nucleus. We call it zinc fingers. Zinc fingers. It's important for DNA transcription. So zinc, vitamin A, steroids, and thyroids. These are the things that work on the nucleus. Okay? Sometimes the steroids will work on the cytoplasm first, then the nucleus afterwards. Okay? Yes, I was going to say it Saturday. Okay? Sometimes the steroids work on the cytoplasm first, then go into the nucleus indirectly. But vitamin A, zinc, thyroid work on the nucleus right away. Okay? Other hormones are cell membrane. Epinephrine, norepinephrine, whatever. All of this is cell membrane. Okay? I believe vitamin D will act also on the nucleus, but it doesn't have too much transcriptions, right, Imani? Vitamin D only important in absorbing calcium and phosphorus from the GI. Okay, but yes, it can cross the cell membrane, Imani. Okay, yes, work on the cytoplasm, then work on the nucleus. Okay, now here, these are the fat soluble vitamins, guys. Vitamin A, we said it will cause night blindness, xerophthalmia, bite spots. Vitamin D is important to absorb calcium and phosphorus. If you have vitamin D deficiency, you will get rickets in children, osteomalacia in adults. Lots of students confuse osteomalacia with osteoporosis. Osteomalacia is problem in calcium and phosphorus. You have low calcium, low phosphorus. So it's a problem in the minerals. So they will say in the exam, literally, that's what you will choose on the exam, defective mineralization of the bone. Defective mineralization of the bone. Osteoporosis, on the other hand, is the bone itself. It has decreased bone density. The calcium and the phosphorus are normal in osteoporosis. Okay? So osteoporosis, normal calcium, phosphorus. There is just a decreased bone density. Osteomalacia, there is decreased calcium and phosphorus. And that's a mistake students do. Students think that vitamin D is important to absorb calcium only, but it secretes phosphorus, like parathyroid. Wrong. Vitamin D absorb calcium and phosphorus, both of them. I remember it's a vitamin. It's never harmful. It usually love calcium and phosphorus equally. So it usually absorb calcium and phosphorus equally. So if you have vitamin D deficiency, both of them will decrease. You will have low calcium and low phosphorus, guys. That's very important. Okay. Now, vitamin E is usually important as antioxidants. So it usually protects the structures from free radicals. So if you have vitamin E deficiency, you will have free radical formation. And we know that free radicals damage the red blood cells. For example, in G6PD, free radicals damage the RBCs. So you will get hemolytic anemia because vitamin E is important antioxidant. You will also have problem in the spinal cord, something called the dorsal column. And that's why you will get loss of proprioception and vibration. Okay, and go back to my neurology webinar in the neuroanatomy. It contains everything in the neuroanatomy in 1 hour on the YouTube channel, and check how we answered spinal cord lesions, guys. Okay, now how about vitamin K? Vitamin K itself is important for something called gamma carboxylation. Okay, which are important for making the coagulation factors. 2, 7, 9, 10. Remember remember this year. So remember 2, 9, 7, 2. Okay. Now 10, 9, 7, 2, sorry. Okay. But remember the word gamma carboxylation. That's what they will ask about on the exam. They will ask about how do you activate the coagulation factors, gamma carboxylation. Okay. The lecture was intended to be 1.5 hours, but I will just take my time to go through all the nutrition. So either I will take 1.5 hours really, or I can take 2 hours. I will see, guys. I will not like leave without going through all the concepts. Okay. Now let's go here, guys. So a 29-year-old woman. So let's answer a question. Okay. Is would vitamin E toxicity cause hemorrhage and vitamin E deficiency cause hemolysis? That's true, but toxicity will never be asked Saturday because toxicity cannot happen really. It's very rare. Okay. So toxicity is very rare. Okay. Now let's go through here. Thank you, guys. So a 29-year-old woman on isotretinoin develops nausea, headache, and papilledema. And this happens in fundoscopy. What do you think? Very revision, guys, huh? Revision. What do you think this person is having here? Some students always confuse. How do I know deficiency from toxicity? I remember toxicity, so it accumulate on the brain. So it will cause pseudotumor cerebri. So I remember toxicity, it accumulates. So it will cause pseudotumor cerebri. That's how I remember it. So it would be hypervitaminosis A. Too much vitamin A, toxicity. When you have too much vitamin A, it will accumulate on the brain, guys. That's why it will cause toxicity. Okay, that's why it will cause toxicity. Now, vitamin A deficiency. This will cause the white spots and night blindness. Okay, this person here has nausea, headache, papilledema. That's increased intracranial pressure. So this would be pseudotumor cerebri. Now, how about vitamin D toxicity? If you get vitamin D toxicity, you will get too much calcium and too much phosphorus. Okay, hypercalcemia and hyperphosphatemia. How about niacin deficiency? Niacin deficiency will cause pellagra or the 3D, right? 3D, diarrhea, dementia, dermatitis, and death. Good. Or 4D, yes, Howling. And then zinc, we said zinc will be important. I remember zinc, whenever I mention zinc, I remember the mouth and the genitalia, the two orifices. So I remember it will cause dermatitis on the mouth, dermatitis in the genitalia. And in the mouth, it will affect the smell and the taste. Okay, so the dermatitis in the mouth and genitalia and the smell and taste. That's zinc deficiency. Okay, zinc deficiency. Very good. So that's the vitamin A toxicity. Now here it will cause intracranial hypertension. Very important. Okay, very important. Before giving vitamin A, always check pregnancy test and require 2 forms of contraception. Okay. Now, if you just have time, remember the dosage. When would it be excessive, for example? But I don't think it's a high yield. I don't think the dose is high yield so much. Okay, I will tell you which dose is high yield when we come to it. There is a specific vitamin that you need to know the dose. Now let's go here. A chronic alcoholic presents with confusion, ataxia, and ophthalmoplegia. His glucose is low and he is given IV dextrose. His condition rapidly worsens. What's the diagnosis? Amazing. Very good, Nathania. So think about it, Kinga. Think about it, Imelda. Ishwarya. Very good, guys. Very good. So this person again is alcoholic. Low glucose. And you give him dextrose. Do you remember what will happen? First, they will get refeeding syndrome. Decreased magnesium, decreased magnesium, phosphorus, and potassium. Second, they will get thiamine deficiency. Now, here comes the question. Where is thiamine deficiency here? Because we have Korsakoff, Wernicke, Beriberi. The 3 of them are thiamine deficiency. So B, C, and D can work. The 3 of them can be thiamine deficiency. So how do I differentiate? Wernicke, guys, will usually cause the triad. What's the triad of Wernicke? Confusion, yes. Ataxia, and ophthalmoplegia. I remember it. First, it will affect the eye, ophthalmoplegia, and he can't see. If he can't see, can he maintain the posture? No, he will have ataxia. If he have ataxia and he can't see, he will start to be confused. Confusion, ataxia, ophthalmoplegia. That's the triad. On the other hand, Korsakoff, this is when you start to get Korsakoff, something called confabulation, which is making things up. I remember confabulation like this. Now, why? Why would you get confabulation? Because if you have thiamine deficiency, chronic thiamine deficiency, this can attack a specific structure in the brain called the mammillary bodies. These mammillary bodies, guys, store memory. Remember, mammillary store memory. And if you damage this memory, if I ask you, let's say you have damage to the mammillary body, and I ask you what have you done last week, but you don't remember it, then what will happen? You will start to mix and make things up, right? So you will tell me, oh, I went skydiving or whatever, but you didn't do it. So you will make up stories. And that's what's called Korsakoff. And usually it's a chronic condition. That's how I remember it. Chronic condition. So if you don't treat Wernicke, you can get Korsakoff. But acutely, you get Wernicke first. Then Korsakoff is a chronic condition, confabulation. So here the answer is Wernicke, the triad. Now, how about beriberi? I have wet beriberi from the name wet, so blood. So this one causes heart failure, something called high cardiac output heart failure, wet. And then I have dry, from the name dry, no blood. It just causes peripheral neuropathy. So wet is very wet. So too much blood, high cardiac output heart failure. Dry beriberi can cause peripheral neuropathy. Okay. Now, how about hepatic encephalopathy? This will cause something called asterixis, which is tremors of the wrist. Asterixis. This happens from accumulation of NH4 ammonia, which come from what? The protein. Okay, NH4 ammonia that comes from the protein, or NH3, I believe. I don't know which one, to be honest. Now, central pontine myelinosis. This happens if you affect the bones, and this can cause something called the locked-in syndrome. Okay, locked-in syndrome. And this will cause quadriplegia. Okay, and this happens if you rapidly correct the sodium level. It will cause quadriplegia. Okay, yes, that's the one that happens when you rapidly correct sodium level. And we will explain it, okay? So here, that's Wernicke. Confusion, ataxia, ophthalmoplegia. What's the rule? Give thiamine before glucose, always. If you see a malnourished patient, you always give thiamine before glucose, okay? That's called the coma cocktail. Whenever you see a person in a coma, you give them glucose and the thiamine. And sometimes you give them naloxone in case they have opioid toxicity, okay? Now, so here, wet is high cardiac output heart failure. Dry is peripheral neuropathy. Wernicke, confusion, ataxia, ophthalmoplegia. Korsakoff, you will have confabulation. And it happens from mammillary body damage. It's irreversible, chronic irreversible. Okay, that's very important. Okay, that's a good question, Safi. Why glucose depletes thiamine? No, that's a very good question. Because when you have too much glucose, don't you need to do glycolysis to it? When you give glucose, don't you need to do glycolysis? Now, when you do glycolysis, usually you use thiamine as one of the cofactors in the enzyme pyruvate dehydrogenase. Okay, in the Krebs cycle. Remember, in the Krebs cycle, pyruvate dehydrogenase use B1, B2, B3, and B5 as cofactors. So that's why if you give too much glucose, you will use up the B1 or the thiamine in pyruvate dehydrogenase. So you will have thiamine deficiency. Now, why you will have decreased phosphorus? Isn't when you have galactokinase. Sorry, when you have glycolysis, don't you have an enzyme called the glucokinase in glycolysis? This enzyme you convert glucose into glucose 6-phosphate. So it usually uses phosphate in glycolysis. And that's why if you give too much glucose, you will use too much phosphate to make glucose 6-phosphate. That's why phosphate also decrease sometimes in refeeding, because insulin will make it inside so it can use it up. Okay, that's very important. Thank you, Fels. Now let's go into this one, guys. Like whenever you have questions like this, guys, ask me. Sometimes I know like the information about it, and it can be like easy to comprehend it once you understand the basics behind it. Okay. Now let's see here. A 5-year-old person on a corn-based diet, present with symmetric photosensitivity, skin lesions, diarrhea, and confusion. What vitamin is deficiency here? What do you think, guys? Amazing, good. Amazing, Kahla. Amazing, Sunzo. Not because of Avidin Saturday. Not because of Avidin. Okay? Avidin is for another thing. So here, it's a corn-based diet. So there is 3 causes that can cause this vitamin, guys. First, the answer here is vitamin B3. Why? There is photosensitive skin lesions, that's dermatitis. There is diarrhea, and there is dementia. Okay. Now, so this person have pellagra. Now there is 3 causes that I want you to know about pellagra. The first cause is here, corn. When you take too much corn-based diet, this can cause usually niacin deficiency itself. Okay, corn-based diet, because corn-based diet doesn't have that much niacin. Okay, but the other ways to have niacin deficiencies are very, 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 very important, and I want you to focus on it. Okay, so here, so niacin, guys, is usually made by a specific amino acid called the tryptophan. Okay, and this tryptophan, in order to make niacin with it, or vitamin B3, you need another vitamin as a cofactor, which is vitamin B6 or pyridoxine. Okay, so how can I get vitamin B3 deficiency? First, if I have vitamin B6 deficiency, the most high yield cause is isoniazid. Isoniazid is a drug used to treat tuberculosis. It can cause vitamin B6 deficiency, which can cause B3 because we need B6 for B3. Now, what's the other cause? If I don't have tryptophan, why wouldn't I have tryptophan? The first disease that can cause problems in tryptophan, guys, is a disease called Hartnup disease. In this disease, there is problem reabsorbing a specific amino acids called neutral amino acids, which are tryptophan and the other amino acids you don't need to be aware of. Okay? And because you can't absorb tryptophan from the urine to the blood, you have problem. Tryptophan will decrease in the blood. And this will cause tryptophan deficiency, which will cause B3 deficiency, Hartnup disease. The ways you will ask about it is it's a problem in what? Problem absorbing neutral amino acids. Neutral means it's not an acid and not a base. And the tryptophan is one of these neutral amino acids. The second thing, can you see here, Salma? Can you see Niha? You also need tryptophan to make serotonin. So if you have carcinoid syndrome or serotonin syndrome, you will use all the tryptophan to make serotonin. So you will have no tryptophan left to make niacin or vitamin B3. And this can also cause niacin deficiency, carcinoid or serotonin syndrome. Okay, so here, other ways to have niacin deficiency, Hartnup disease, which is problem in tryptophan absorption, especially neutral amino acids. Isoniazid, because this will cause decrease in B6, which is the one we need for niacin. And lastly, carcinoid, which divert tryptophan to serotonin, so you will have no tryptophan left to make B3 or niacin. So these are the 3 causes of niacin deficiency. Now let's go through the next one. Here, a patient on high-dose niacin for hyperlipidemia develops a painful facial flushing after each dose. What mediates this? What do you think here, guys? What mediates this? That's a very important, Mihak, very important, Kara or Dinah. This would be prostaglandin mediated vasodilation. And I will tell you why. Okay. First, how can you get flushing? You can get flushing by two ways. Flushing means too much blood vessel, okay, and too much blood in the face. There is two important biochemistry ways. Either prostaglandin, which will vasodilate the blood vessels, or histamine, which also vasodilates the blood vessels, right? So either prostaglandin or histamine. Now, niacin itself, if it's excessive, it can cause flushing by secreting too much prostaglandin. And that's why if we have niacin flushing, the way we treat it is by aspirin, because aspirin inhibits the COX enzyme, which is important to make prostaglandin. So we use aspirin to decrease prostaglandin level. So niacin toxicity can cause flushing from too much prostaglandin, and that's why we treat it with aspirin. Okay. Now, when can we get niacin toxicity? That's another question they ask. When you treat hyperlipidemia, because niacin can increase the level of HDL, which is the good lipoprotein. And that's why if you have low HDL, we can use niacin to increase the levels of HDL. So sometimes we can use it for hyperlipidemia, but sometimes excessive intake of it can cause flushing. Okay. Now, sometimes it can also cause gout. Niacin excessiveness can cause gout. So either too much uric acid cause gout or too much prostaglandin to cause flushing. Karim, how about histamine? Histamine can also cause flushing, but a very important disease that increases histamine to cause flushing is usually carcinoid syndrome. And I know, I told you carcinoid is too much serotonin, right? But it's also too much histamine, okay? And this can cause flushing in the face. So carcinoid syndrome and usually niacin itself, niacin toxicity, both of them can cause flushing, but by two mechanisms. Carcinoid will secrete histamine, and niacin will secrete prostaglandin. Okay? So here, that's niacin from too much prostaglandin. And that's why you do pre-treatment with aspirin to reduce niacin-induced flushing. Okay? Take care, other side effect is hyperuric acidemia, gout, and the hyperglycemia also sometimes. Why do we use niacin? To increase HDL. That's the most important thing. Remember, we have a statin to decrease LDL. Remember, we have fibrates to decrease triglycerides, right? Then we have niacin, most importantly, to increase the HDL. Okay, guys? Now, let's check this. A chronic alcoholic has fatigue, burning feet, diarrhea, and scaly perioral dermatitis and patchy alopecia. Which deficiency best explains this? This vitamin is very important for the hair. And you will mention a lot that we take it in hair like supplements. Okay, to grow your hair back. I usually take it because I have androgenic alopecia here. Okay. Now, which vitamin is this? So when you have deficiency of it, you can get patchy alopecia. That's very important. Amazing, Imani. Amazing, Rodina. Very good, Barkay. Good, Tah. This would be vitamin B5, guys. Pantothenic acid. The only thing that I want you to know about vitamin B5 or pantothenic acid is that first, the other name of it is called the coenzyme A, which is important for fatty acid metabolism. That's the other name of it, because they will tell you what is coenzyme A. Okay? The other thing that I want you to know is that it's very good for the skin and for the hair. So problems on it can get you alopecia, enteritis, dermatitis. Okay, and sometimes it can cause adrenal insufficiency, but it's not that important cause. So please take care. Vitamin B5 can usually cause alopecia, and it can sometimes also cause dermatitis. Okay, and sometimes adrenal insufficiency. Okay, now, but it's not the most important cause of adrenal insufficiency. The most important cause of adrenal insufficiency, of course, is autoimmune destruction, tuberculosis, and also Neisseria. Neisseria can affect the adrenal gland. That's called Waterhouse-Friderichsen syndrome. So that's not the most common cause here. Okay. Now let's see here. A woman being treated for pulmonary tuberculosis develops numbness and tingling in her hands and feet for several weeks. She also reports irritability, difficulty concentrating. Which of the following deficiencies best explains her symptoms? Amazing, Christine. Amazing, Dinese. Amazing, Rosé. Very good, Ifania. Good, guys. Good. Amazing. So here, guys, a person being treated for TB, now they develop numbness and tingling in the feet, peripheral neuropathy. Once you see peripheral neuropathy after being treated for TB, always think about B6 deficiency or pyridoxine. Guys, don't remember B6 without remembering that it's called pyridoxine. Don't remember B12 without remembering it's called cobalamin. It's extremely important to remember these names of the vitamins because sometimes on the exam they will not say B6, they will say pyridoxine. So it's very important to know other names of drugs. Okay. Now, if you have B6 deficiency, guys, what would you get? Okay. First, you will get peripheral neuropathy. But there is another very important thing, which is that B6 can also get you what else? B3 deficiency. That's very important. The third thing, Safi, is that B6 can also get you sideroblastic anemia. Okay, that's extremely high yield. Sideroblastic anemia. So B6 can cause sideroblastic anemia, can cause B3 deficiency, can cause peripheral neuropathy. Okay. And that's no different than B9 and B12. Because B9 and B12 will cause megaloblastic, not sideroblastic. Okay? And usually B12 will cause affection of the nerves also. So it can confuse you. But if you see sideroblastic, which is microcytic, that's B6. If you see megaloblastic, that's B12 and B9. Okay, guys? So that's here is pyridoxine. I want you please to know that it can cause peripheral neuropathy, sideroblastic, B3. The other thing that I want you to know is that sometimes on step 1, they ask you, this specific enzyme need what cofactor in order to work. So the way I remember it, okay, is that, and that's very important, guys. The way I always remember it is that pyridoxine is the one I will choose if I don't know which cofactor or which vitamin is used as a cofactor. Because pyridoxine is cofactor for too many pathways. For example, pyridoxine is very important for AST and ALT, for transamination. It's very important for making GABA. It's very important for any enzyme that's called decarboxylase. Decarboxylase. Okay? So decarboxylase, AST, making GABA, it's very important to make heme. That's why it will cause sideroblastic anemia. So if you don't know which vitamin is important as a cofactor, usually choose B6 and it will not be the wrong answer. Okay? B1 is cofactor for any enzyme that has the name dehydrogenase. So when we say like pyruvate dehydrogenase, branched chain amino acid dehydrogenase, any enzyme that has the name dehydrogenase, B1 will be the cofactor. Okay, and also transketolase. Yes, Susi. But B6 is decarboxylase, AST, okay, and also GABA synthesis. Now, let's continue what we started. Okay. So now let's go. We finished the most hard part, which was usually like the hard vitamins and the hard part, which was also the carbohydrates. Now we have few high yield concepts that I need you just to be aware of. So we'll go through them a little bit fast, okay? Now, the first concept here, okay, is that a child who consumes multiple raw eggs, shakes daily, develops dry skin, alopecia, and irritability. Which of the following best explain these findings? What do you guys think? Once you consume raw eggs, that's literally the only way they will ask about it. Yes, Saturday. Amazing Kinga. Amazing Maria, Rodina. So for this one, guys, they said raw eggs, right? So once they mention raw eggs, I always need you to think about B7. But again, is it enough to know the number? No, you need to know the full name. Biotin deficiency. Okay, guys? Biotin or B7 deficiency can happen when you consume raw eggs. Why? Raw eggs have something called avidin. And I remember avidin will bind avidly to vitamin B7 in the stomach, and it will prevent its absorption. So if you consume too many raw eggs, you will have biotin deficiency. Okay, you will have biotin deficiency. Now it can also cause alopecia similar to B5. They will not make you choose between them. They will not make you choose between them. Okay, unless they mention raw eggs. If they mention raw eggs, then you know right away it's biotin. Now biotin is important. That's a high yield fact for carboxylations. Do you remember B6? We said B6 is decarboxylation. B6 is decarboxylation. But B7 is carboxylation. So the carboxylation one is B7. The decarboxylation one is B6. That's very important. Okay, that's very important. Now, they will also ask you why eggs. Okay, because usually raw eggs have avidin. And that's why, which will bind to vitamin B7. You need to cook eggs. And usually cooking eggs will denaturate the avidin and it will no longer bind biotin and it will treat the condition. So it's mostly from raw eggs itself. Okay. Now, let's see here. This one. A pregnant woman with epilepsy deliver a newborn with a lumbosacral neural tube defect associated with a small overlying tuft of hair. Maternal use of which of the following medications most likely contributed to this condition? What do you guys think here? Rodina, Rosen. Very good. Amazing, Goda. Amazing, Bro Halda. Very good, guys. Very good. Amazing. Guys, usually focus here. We make, and that's very important to Marlene, we make the spinal cord and the brain, both of them are part of the central nervous system. And we make the central nervous system from the neural tube. Okay. Now, in order to form this neural tube, we always need vitamin B9 or folic acid. And that's why pregnant people, we always give them folate 1 month before pregnancy. Okay. Now, anti-epileptic drugs like valproic acid, carbamazepine, phenytoin, they can cause folic acid deficiency. And that's why they can cause neural tube defect. This can either affect the spinal cord, which can cause something called spina bifida occulta meningocele myelomeningocele. This person here with a tuft of hair in the lower back is a spina bifida occulta. Okay? Or it can affect the brain and cause anencephaly, which is absent brain. Now, what other drug I want you to know that can cause this? Folic acid deficiency, and we prevent it with folinic acid other than carbamazepine and the valproate and all of this. Which drug we prevent its toxicity by folinic acid or leucovorin, which is the active form of folic acid? What do you guys think? This drug inhibits dihydrofolate reductase and it's used as a chemotherapy. Amazing. Methotrexate. So methotrexate, guys, can also cause folic acid deficiency and we prevent this by folinic acid. That's the two things I want you to know. Okay? So here, that's a folate deficiency during pregnancy. Folate is essential. That's very important, especially for the neural tube. Now, that's the dose I want you to know. I want you to know we need about 400 to 800 milligram per day. So it's about 0.4 micro mcg or micronogram or whatever, which is about 0.4 milligram, 0.4 milligram. But if you are taking verapamil or anti-epileptics, then you need to take 4 milligrams, not 0.4, which would be like 4,000 mcg. Okay, so take care of this. Usually normal people will take 0.4, but people taking valproate dinase, they will need more dosage of folic acid. So they will need 4 milligrams. or 4,000, like this microgram thing. So very important. To normal people, you give them 400, which is 0.4 milligram. But people that are taking valproic acid or antiepileptics, you need to give them 4 milligrams of folic acid to prevent neural tube defects. Okay, any anti-epileptic. Okay, any anti-epileptic, but valproate is the most common cause. Okay, in the most common cause. Yes, Shahada. Okay, now how about this one? A chronic alcoholic present with fatigue, progressive weakness, physical exam shows a smooth erythematous tongue, and the blood smear is shown here. Additional testing is most likely to show which of the following. What do you think? So this person, guys, is having what? This person is having smooth erythematous tongue, fatigue and weakness, but there is here, and that's very important, hyper-segmented neutrophils. Okay? Once you see hyper-segmented neutrophils, always think about megaloblastic anemia. Hyper-segmented, they have multiple segments, right? Think about megaloblastic anemia, which can be caused by B9 or B12. Okay? Now, B9 or B12. I will tell you why. I will tell you why. What's the importance of B9 and B12, guys? They are usually important to make pyrimidine, which is the base that we use, pyrimidine and pyrene, we use them to make DNA. Now, if you have a large cell, okay, and you need to divide it into small cells, don't you need the DNA to replicate? DNA replication. So if you have B9 and B12, the cell will not replicate. And that's why the cell will be very large. And that's why you will have macrocytic anemia, large RBCs, and also hypersegmented neutrophils because they cannot divide. Okay. Now, what's the difference between B9 and B12? Okay. First, B9 is the one that most commonly happens in alcoholics. B9 folic acid happens in alcoholics. B12 usually happens in vegans and happens also in something called pernicious anemia. B9 doesn't cause neural symptoms. B12 will affect the nerves and it will cause neural symptoms. So here this person is alcoholic and he doesn't have any neural symptoms. Okay, so this one is folic acid deficiency. Now, folic acid deficiency, guys, usually increase homocysteine, but it will cause normal methyl malonyl acid. But B12, I remember 12 has 2 on the name. It will increase both of them. It increases homocysteine and also methyl malonic acid. So B9 only increase homocysteine. It will cause normal methyl malonic acid. Okay? But B12 will increase homocysteine and will cause also increase in methyl malonic acid. Okay? So here, guys, that's folate. It happens in alcoholic patients, okay, in weeks. And usually it will increase homocysteine, okay? But only B12 that will increase methylmalonic acid. That's very important, okay? Because we only need B12 to convert this methylmalonic acid into something called the succinyl-CoA. And if you have B12 deficiency, you will have increase in methylmalonic acid, okay? But on the other hand, folate itself and the B12, both of them are important for homocysteine to convert it into methionine. And that's why both of them will increase homocysteine. Okay, so that's here, guys, is usually folic acid only because he's alcoholic. So there is increase in homocysteine and there is normal methylmalonyl-CoA and there is no neurological symptoms exactly so. Okay, so here it's folic acid deficiency itself. Okay, now let's see the other one. The other one. Okay, a 32-year-old woman presents with type 1 diabetes mellitus due to progressive fatigue, difficulty walking, and the physical exam shows decreased vibration in both lower extremities and a smooth erythematous tongue. Laboratory studies reveal macrocytic anemia with hypersegmented neutrophils. Further evaluation is most likely to demonstrate which of the following. What do you guys think here? Amazing Maria, amazing Cardora, Nathania, Cara. Perfect, guys. Perfect, Dinese. Amazing. Okay. So what did we say, Nils, about this one? We said this person here is having also hypersegmented. So we know it's either B12 or B9. But there is also decreased vibration sensation. Usually B12 guys can cause something called subacute combined degeneration, which is that it will affect the dorsal column and the corticospinal tract. So it will cause problems in vibration and the problems in the corticospinal upper motor neuron lesions. Okay, so here we know it's B12, not B9. Now, what's the cause of this? The key word to know the cause of this, Rodina, is from the history of type 1 diabetes. Type 1 diabetes, guys, okay, once you see this, or once you see hypothyroidism, usually you need to know that this person have an increased risk of other autoimmune conditions. If you have type 1 diabetes, you have an increased risk of hypothyroidism. You also have an increased risk of pernicious anemia. You have an increased risk of vitiligo. So autoimmune conditions usually show up together, okay? And that's why probably the cause of B12 is an autoimmune condition, especially something called anti-intrinsic factor antibodies, which is usually pernicious anemia. This person is having auto-antibodies against intrinsic factor. And remember we said intrinsic factor is important to absorb vitamin B12. It's secreted in the stomach, it will bind to B12 and it will make B12 absorbed in the terminal ileum. So this person here is having this pernicious anemia, which is antibodies against the intrinsic factors. Okay, so that's always a rule. If patient have if patient have autoimmune condition, look for other autoimmune diseases. Yes. Now, John is asking, what's the significance of the person erythematous tongue? This is called glossitis, and it usually happens in vitamin B deficiency, any B. And that's why I don't want you to focus too much on it, because it can happen in multiple vitamin B deficiency. It's not specific for any vitamin B specifically. Okay. Now, what is anti-endomysial antibodies with iron deficiency? That's here is celiac disease. Didn't we say celiac affects the duodenum? So it will cause iron deficiency anemia because you absorb iron in the duodenum. And it's anti-endomysial antibodies. What is low cerebroplasmin level with microcytic anemia? Low cerebroplasmin level will cause copper accumulation. That's a disease called Wilson, which is usually accumulation of copper in the liver and in the brain and in the eye, Kaiser-Fleischer rings. Okay. Spectrin and ankyrin, that's usually hereditary spherocytosis. Hereditary spherocytosis. Amazing, guys. Amazing. And of course, decreased folic acid is wrong because this person doesn't have normal neurological examination or B9. Okay. So the difference between folate and B12, folate, no neurological sign. B12 will cause neurological sign. Homocysteine is elevated in both of them, but methylmalonic acid is increased only in vitamin B12. B12 take years in order to deplete if you are vegan. Folic acid take weeks. Okay. And a common cause of B12 is pernicious anemia and veganism. And also Crohn's. Do you know why Crohn's can cause B12 deficiency, guys? Huh? Don't you remember where did we say B12 will be absorbed on? Where would it be absorbed? Amazing. Amazing. The terminal ileum. Guys, we have jejunum, duodenum, ileum. Duodenum absorb iron. Jejunum absorb B9. Ileum absorb B12. Crohn's affect the ileum, so it will cause B12. Celiac affect the duodenum, so it will cause iron. Okay. So yes, iron first, bro, then B9, and then increase the number, B12. So duodenum, jejunum, ileum, iron, B9, B12. Crohn's affect the B12. So it will also cause B12 deficiency because it affects the ileum. Okay. Now this one is a little bit easy because I told you about it. Never get it wrong. Let's see. A 9-month-old boy exclusively breastfed is brought to the clinic for delayed setting and poor growth. Physical exam shows widened wrist, both legs. X-ray demonstrate metaphyseal cupping and fraying. Which laboratory pattern is most likely present? Now, amazing, Iphigenia. Amazing grammar. Very good, Kinga. Perfect. Perfect, Christina. Perfect, Albert. So, what did we say, guys? When you see a person exclusively breastfed first, I need you to think about vitamin D deficiency because vitamin D is not found that much in breastfed. Okay. Then when they mention the late setting and problems in the wrist and the bone, that's usually vitamin D deficiency, which is called rickets in boys, osteomalacia in adults, rickets in kids. So that's here is rickets. Okay. Now, don't you remember what did we say about the vitamin? We said it absorbs both calcium and phosphorus, both of them. So if you have D deficiency, you will have decreased the calcium, decreased the phosphorus. How about the parathyroid hormone? It will increase in order to compensate. So here we'll choose decrease the calcium, decrease the phosphorus. Parathyroid hormone, when it sees a decrease the calcium, it will increase. Okay. So that's called rickets, guys. Okay. Now, how much unit we need to give? 400 units. Okay. So don't remember those. 4. Folic acid with 0.4 milligram. Okay. Or 4 milligram if you are taking seizures. Vitamin D is 400 international units. IU means international units. Okay. Now, rickets, we said in kids, in adults, it's called osteomalacia. Okay. So that's pretty important. Where do infants get vitamin D? So usually they are very deficient on it. Yes, the milk have it, but very low, Safi. And usually the ways you can get it, okay, is by the supplement. There is no other way. When you get older, you get it from sunlight, but it's not that important, but you get it from eggs and the liver and the meat, things like this. Okay. Now, that's why African Americans can have more likelihood of getting vitamin D deficiency. Do you know why? Because African Americans, they have too much melanin. It protects them from ultraviolet ray. Is this good or bad? That's good because it decreases the risk of cancer. But ultraviolet ray, which come from the sun, is important to activate vitamin D, right? So usually African Americans, yes, you protect them from cancer by having too much melanin, and this will have decreased risk of cancer. But we also will have increased risk of vitamin D deficiency because there is no ultraviolet rays to activate vitamin D. Okay, that's very important. Now, let's see this question here. A 6-year-old boy with cystic fibrosis. I don't even need to continue, but here they want me to continue for one reason. There is difficulty walking and poor coordination. Probably there is affection of the dorsal column. There is bulky foul smelling stool. Okay, and the physical exam shows hemolytic anemia. Which vitamin we said is an antioxidant. So if you have deficiency of it, you will have free radical damage of the spinal cord, dorsal column affection, and also of the RBCs, so you will get hemolytic anemia. Very good. Amazing. Amazing, Raza. Amazing, Mariana. So this would be vitamin E deficiency, guys. First, this person have cystic fibrosis, so it's ADEK, it's not B12. When you told me E, guys, I thought you meant option E. I was going to have a heart attack because we know B12 will not cause hemolytic. It will cause megaloblastic and it's not fat soluble. Okay, so here it would be vitamin E deficiency, and the vitamin E will affect the dorsal column and it will cause hemolytic anemia. That's very important. Okay, so pretty good. So that's a vitamin E, guys. They ask about it. Why does this person have fat malabsorption? Because they have cystic fibrosis. What can also cause this? If you have cholesteatosis, you can get also fat malabsorption. Something called a beta lipoproteinemia. This one, A means absent. This one, you have absent lipoprotein. You don't have fat because you can't absorb fat in the GI. That's called a beta lipoproteinemia. And premature infants will also sometimes get fat malabsorption. Okay, so that's the thing. Now, that's very important for vitamin E deficiency itself. Okay. Now let's see this one here, guys. A 14-year-old boy with cystic fibrosis again, but this time there is easy bruising and the gum bleeding, and there is prolonged BT and normal BTT. What's this? What do you think, guys, here? Amazing. Amazing, Berkay. Amazing, Neha. Amazing, Cordero. Perfect, Dinese. Guys, this is the other ADE key. Which one is important for coagulation factors? Gamma carboxylation of coagulation factor. Very important. Vitamin K, good. That's important for the coagulation factors. Okay. Now, do you know where is usually vitamin K synthesized from? What's the source of vitamin K? Good. We take leafy vegetables, so green vegetables, and also the GIT bacteria. So the GI bacteria are important for vitamin K and also leafy vegetables, both of them. So if you take warfarin, guys, which usually inhibit vitamin K, right? Don't take antibiotic with it. Do you know why? Huh? When you usually take warfarin, don't take antibiotics with it. Because if you take antibiotics while taking warfarin, this can inhibit the GI bacteria itself. This can kill the bacteria, okay? And this can cause some kind of vitamin K deficiency, problems in vitamin K and vitamin K deficiency, okay? Also, you need to take adequate leafy vegetables. Also, sometimes the preterm kids can have vitamin K deficiency because preterm kids do not have GI bacteria. They do not have GI bacteria. Okay, they have a sterile GI, no GI bacteria. So that are one of the causes of vitamin K. Okay, so vitamin K here important for gamma carboxylation of these coagulation factors. Okay, antibiotics will kill the GI bacteria, and this can cause vitamin K deficiency, especially when you take warfarin. Remember, warfarin inhibit vitamin K epoxide reductase, which is the enzyme that activate vitamin K, guys. Okay, so that's very important. Now, John is asking, why normal BT? Why normal BTT? Why increase the BT only? We said vitamin K inhibit 9, 10, 7, 2. Okay, but which coagulation factor is the one that has the shortest half-life and the first one to deplete? 7. Yes. And the 7, guys, is important for the extrinsic pathway that usually is monitored with PT. And that's why if you have vitamin K deficiency, you monitor BT will be increased. Also, if you take warfarin, you monitor it with BT. BTT have very long half-life. This person is probably coming to you with acute vitamin D deficiency. That's why BT will be prolonged, but BTT will be normal. So increase the BT because factor 7 is the shortest half-life. Okay, that's very important. There is another question on one of the nbmes that factor 2 is the longest half-life. 2 is very long, but 7 is the shortest. Okay. Now, how about this one, guys? What do you think? We just have about 30 minutes, guys. Okay. A 64-year-old man with alcohol use disorder, present with fatigue and leg pain. Physical exam shows peripheral hemorrhage and ecchymosis over the lower extremities. Laboratory studies reveal normal PT and PTT with prolonged bleeding time. Deficiency of which of the following biochemical process is most likely the explanation of this concept? What do you think, guys, here? Amazing Maria, amazing Goda, amazing Kinga. Guys, you need to know this. That's like extremely high yield. Okay? Vitamin C itself is very important in hydroxylation of collagen. And if you have vitamin C deficiency, you can't hydroxylate collagen. So you will have a scurvy, which is collagen deficiency. If you have collagen deficiency in the gum, you will get gum bleeding because the blood vessels are very fragile. If you have collagen deficiency in the hair, you will get perifollicular hemorrhage. Okay, so usually what will happen is that you will start to bleed, and that's why you will have increased the bleeding time. Bleeding time means if I cut you, how much time it take you to form a thrombus and to stop the bleeding. So vitamin C will increase the bleeding time, but not because it affects the platelets. It doesn't affect the platelets. It just causes the blood vessel to be very fragile. Okay, and that's why it will cause very easy bruising. So it's not related to coagulation factors, not related to platelets. Now, when do you get vitamin C deficiency? We know that vitamin C usually come from fruits, right? So usually you get them if you are not eating fruits, either in all the people on tea and toast diet or in sailors. Long time ago, sailors who were sailing on the ocean, they didn't have any like fruits because fruits do not grow on the ocean. They only eat fish, for example. And that's why usually sailors a long time ago, they got scurvy. Okay. Now, so here that's the scurvy. It's very important for hydroxylation of collagen. That's extremely high yield. It will cause the blood vessel to be fragile. That's why it increases bleeding time. But it doesn't affect the platelets, doesn't affect the coagulation factors. Okay? So that's for C deficiency. Let's go into the other concept. A person is having severe flank pain and hematuria. CT scan shows a renal stone. He has been taking large amounts of over-the-counter supplements to boost immunity. Excess intake of which of the following vitamins contributed to this? What do you think? Amazing, guys. Perfect. Perfect, King. Here is the thing, Safi. Usually, we have the most common kidney stone is called the calcium oxalate. But do you know why we get it? We don't get it from too much calcium. We usually get it sometimes from too much oxalate. Too much oxalate binding to the calcium. And the vitamin that can cause too much oxalate is usually vitamin C. Okay? Vitamin C can cause too much oxalate, it can cause kidney stones. Now, can vitamin D increase calcium and cause kidney stones? Sometimes, very rarely, it will do this. But this person is taking vitamins to boost immunity. So first, we know it's vitamin C. Second, the vitamin C is the most and the more common cause of kidney stones. Vitamin C toxicity. So now deficiency causes scurvy. Toxicity will cause nephrolithiasis, which is usually kidney stones in the or stones in the kidney itself. And remember, the most common kidney stone is calcium oxalate. That's something they ask about. Okay. Now let's go very fast through the minerals, guys. A patient present with muscle cramps, perioral numbness, and the painful carpal spasm during blood pressure, cuff inflation after thyroidectomy. Which of the following laboratory abnormality is most likely present? What do you think, guys, here? Amazing, Dinese. Amazing, Kara. Kara. Very good. Very good, Maria. So, guys, when they mention muscle cramps, perioral numbness, that's very important. Or carpal spasm after cuff inflation, or something called, that's called Rousseau sign, or something called the Chauvistic sign. When I touch the face, I irritate the facial nerve and there is numbness. Always think about calcium deficiency, which can cause tetany. Okay, that's because when you remove the thyroid, you can remove the parathyroid gland by mistake, and this can cause decreased calcium level. Right, guys? Now, decreased calcium level can also happen from blood transfusion. That's very important because blood transfusion has something called citrate, which usually chelate the calcium. So blood transfusions and thyroidectomy, both of them can cause calcium decrease. Okay, guys? Now, calcium increase, on the other hand, will be the one that will cause stones, groans, psychic overtones. Okay? So it will cause kidney stones, constipation, abdominal pain, and psychic problem. I remember too much calcium will accumulate on the kidney stones, will accumulate in the intestine, so it will cause constipation, will accumulate in your brain, so it will cause psychiatric problem. That's too much calcium. So there is a difference between too little calcium and too much calcium. Potassium, either high or low, will cause muscle weakness, affect the muscle. Okay? But low potassium will cause flat U wave or flat T wave. High potassium will cause hyperacute T wave. I remember too much potassium will accumulate under the T wave, so it will cause high T wave. But too little potassium will cause flat T wave. Okay? Magnesium increase is not important. Magnesium decrease is important. Why? If you have hypomagnesemia, you can get hypocalcemia and the hypokalemia that are not responsive to treatment. If I tell you a person have hypokalemia, you give him potassium, there is no improvement. Think about hypomagnesemia. So hypomagnesemia will cause decreased potassium and decrease the calcium that are not responsive to treatment. Okay? The last thing is hyponatremia. This can cause seizures, and if you correct it rapidly, you will get osmotic pontine demyelination. Okay, so that's all of the things I wanted you to know. So here, guys, that's decreased the calcium. Why? Because decreased the calcium will cause chauvinistic sign. So that's when you touch the face, you activate the facial nerve number 7, and this can cause the facial twitching, and also can cause truaceau sign, carpal spasmus, blood pressure cuff, and this can cause other things. Okay, but I want you to know about these ones. Now, what are the causes? If you have hypoparathyroidism, if you have vitamin D deficiency, if you have hypomagnesemia, this can cause hypocalcemia, and the pancreatitis. Something I want you to know about pancreatitis, guys. Hypercalcemia can cause pancreatitis, but pancreatitis itself will result in hypocalcemia because it can cause something called the saponification, which is that fatty acid will bind to calcium and decrease the calcium. So again, what's the cause of pancreatitis? Hypercalcemia. What's the result of pancreatitis? So the result of pancreatitis is that you will get hypocalcemia. So hyper is the cause. Then you get pancreatitis, then it will result on hypocalcemia. That's very important. Okay. Now, let's go into this one here. So a chronic alcoholic is brought to the emergency department because of tremors and generalized tonic-clonic seizure. Laboratory studies shows persistent hypokalemia despite aggressive potassium supplement. Which of the following electrolyte most likely explains this? And that's the most common electrolyte abnormality in alcoholics. What do you think, guys? The most common electrolyte abnormality in alcoholics. Pretty good. Amazing, guys. Perfect. Hypomagnesemia. Okay? Hypomagnesemia, guys. If you have hypokalemia refractory to treatment or hypocalcemia refractory to treatment, then think about hypomagnesemia. Okay? So here that's hypomagnesemia, guys. Pretty good. Pretty good. How about this one? A hospitalized patient developed progressive muscle weakness and constipation. ECG demonstrates flattened T wave and prominent U wave. Which of the following electrolyte abnormality is most likely present? What do you guys think here? Amazing, Kinga. Amazing, Maria. Very good, Sarah. Very good, Rama. Perfect. Perfect. Guys, whenever you have flattened D wave, think about decreased potassium. But hyperacute T wave, think about increased potassium. Both of them can cause muscle weakness. Both of them will cause muscle weakness. Okay, so that's pretty important. Now, how about this one? We are just like refreshing what we have said. A hospitalized patient developed confusion and seizure due to severe electrolyte disturbance, seizures. His neurological symptoms initially improve after treatment, but several days later, he developed dysarthria, spastic quadriplegia, and pseudo bulbar palsy. Rapid correction of which of the following abnormality is most likely the cause? What do you think, guys, here? Perfect. Amazing, Rosé. Amazing, Nelsa. Very good, Emarza. Guys, this person is having quadriplegia. When you have a person with quadriplegia, always think about osmotic pontine demyelination syndrome. Okay? And or locked in syndrome. We call it locked in syndrome because the person is locked inside his body. And that's usually, Ahmad, from rapid correction of hyponatremia. And I will tell you why. If you rapidly correct hyponatremia, it means you give the person too much sodium, right? If you give the person too much sodium in the blood vessel, what will happen to the fluid inside the brain? It will go to the blood vessel, right? So you are literally sucking blood from the brain. When you do this and when you suck fluids from the brain, this can cause the fluid to be shifted from the brain, and this can cause something called demyelination of the bones. The bones will, the myelin sheath will be very dry and it will start to demyelinate. Okay. Now, yes, the only ways you will communicate is vertical eye movement. They move their eyes up and down only. Very good, Bruna. Okay. Now, so here that's hyponatremia. And usually, if you rapidly correct it, you can have osmotic pontine demyelination or locked in syndrome. okay, or locked-in syndrome. Okay. Now, we will go into the minerals. I know, guys, I went through the electrolytes fast because I know it's a nutrition, but usually we'll discuss it, or probably we discuss this in other concepts. And again, I understand that some of you may need more explanation of this topic or any other topic, and that's why that's just like a glimpse of what we will do in the 7-day USMLE crash course. It's a 7-day USMLE crash course. We go through the most high-yield stuff in 7 days. And you can also try me or any of our amazing tutors for a free 30-minute session. And if you like it, you can commit to one of the packages. Now let's go here to the minerals, guys. Okay. So let's see here. A young boy develops a chronic diarrhea, perioral and acral dermatitis, alopecia, and decreased sense of taste several months after being weaned from breastfeeding. Physical exam shows delayed sexual maturation. Which of the following explains the patient condition? What do you think, guys? Thank you, Susie. Thank you, Natalia. Rosie. Amazing, Janan. Very good. Very good, Brunhilde. Very good, Sus. Very good, Nia. Salma. Amazing. Did you remember, guys, what did we say, Lucia? We said what specific mineral will affect the mouth, will affect the genitalia. So that's very important, right? When it affects the orifices, right? It will cause perioral problem, dermatitis. It will also cause affect the genitalia, so it will cause genitalia dermatitis, right? It will also cause problem in sexual maturation. Didn't we say it affects the genitalia? So it will cause dermatitis and the problems in maturation and like testicular atrophy. Okay? And didn't we say it will affect the mouth? So it will cause what? It will cause problem in taste and anosmia also, smell. Pretty easy, right? So it would be zinc. And remember we said zinc act on the nucleus, zinc fingers act on the nucleus to do DNA transcription. Okay. Now, selenium, copper, we will discuss them. I don't want to ruin it for you here. Niacin, we already discussed this. And remember, niacin is important, and we make it from tryptophan using B6. Biotin is the one for avidin, raw eggs. Okay. So here, zinc, we talked about it. It work on the DNA, zinc fingers. Okay. And you will have dermatitis, diarrhea, anosmia, dysgeusia, which is like you can't smell, hypogonadism. Very easy. Mouth, genitalia. Okay. Now, excess zinc, if you use too much zinc, you can get copper deficiency. So what would copper deficiency cause? Okay. Copper deficiency usually cause anemia and the problems in the collagen, but we will have a question on it, so I don't ruin it for you. Okay. But I want you to know excessive zinc can cause copper deficiency. If you take too much zinc, you can have copper deficiency. Okay. Selenium is usually important for the hair, right? And also for the thyroid gland, and also for the heart. So if you have selenium problems, you usually can have dilated cardiomyopathy and hair problems, and usually thyroid gland problems. Okay, that's the selenium. So selenium is for the hair, the heart, and the thyroid. Chromium is very important for glucose. They will tell you a person have hypoglycemia and you give him insulin and there is no improvement. If there is refractory hypoglycemia, think about chromium. So now we have two refractories. Refractory hypokalemia, hypocalcemia, think about magnesium. Refractory hypoglycemia, think about chromium. Okay. Now, iodine, we know about it. It's important for thyroid itself, so it will cause thyroid problems. Fluoride is important for the tooth, and that's why they usually put fluoride in the toothpaste. And if you have fluoride deficiency, you can get dental caries. Okay, that's very important. And that's why usually in young people, and usually in general, we put fluoride in the water. So the water you are drinking now has fluoride. And how they will ask about it, they will tell you a person is drinking water from a well. Now, does the well has fluoride? It doesn't have fluoride because it's not like fluoridized by the country. And that's why he is drinking water from the well. Now he have teeth problems. What's the deficiency here? Fluoride deficiency. Okay, guys, that's very important. And the last thing is manganese, which is not even important at all. Okay, not even important at all. Yes. And if you guys indulge into the minerals, you will see these have very, very many keywords. And if you try to study minerals yourself, you will see it has keywords, you will feel lost. And that's why I need you to focus on these specific keywords we discussed. We discussed here mouth and genitalia. Now let's discuss the other keywords for the other questions. A patient receiving long-term total parenteral nutrition. Without micronutrient supplement, he develops progressive fatigue and exertional dyspnea. There is proximal muscle weakness and dilated cardiomyopathy. Which of the following deficiency most likely explains this patient finding? Which one is important? For the heart, for the muscle, for the hair? What do you think, guys? It's used in a shampoo. We even use it in shampoos because it's important in hair, but it can affect the heart and the muscle. Amazing, amazing, Safi. Amazing, Imelda, Maria, Iman. Perfect, guys. So this would be selenium, guys. Okay, selenium itself, okay, is important for the hair, for the heart, and for the muscle. And we said it's also important for the thyroid. It can cause similar symptoms to hypothyroidism. Okay, now let's see the other one. A patient receiving long-term total parenteral nutrition have progressive weight loss, peripheral neuropathy, and persistent hyperglycemia. Yeah, hyperglycemia. Sorry, I said hyper. Despite giving insulin. He has no prior history of diabetes, deficiency of which of the following trace elements most likely is the cause. Hyperglycemia, resistance to insulin, not hypo, I'm sorry. Of course, you don't treat hypo with insulin. Amazing. Amazing, Brunhilde, amazing honor, Kahla, Kinga. Very good, guys. So for this one, it would be chromium. Yum, because it's yummy, it will increase the glucose level and it will be resistant to insulin itself. Cream yum, okay? So I'm trying to invent some mnemonics here so we can remember it because even me, I will forget about it after the lecture, by the way. Okay, now let's see here. A patient who has been taking high dose zinc for several months, develop fatigue, get instability and numbness in both legs. Exam shows anemia that doesn't improve with iron therapy and neutropenia. Vitamin B12 and methylmalonyl oxalic acid are normal, which of the following best explains this? Hi guys, so if you give high dose zinc, then you get neurological problems and anemia. What do you start to think? Very good, amazing. Copper deficiency. High dose zinc can cause copper deficiency. There is also another disease that can cause inherited copper deficiency. Menkes. Do you know what gene is problematic in Menkes? What gene is problematic in Menkes? There is a specific gene abnormality called, yes, very good, guys. There is so, yes, problem in lysyl oxidase and this gene ATP7A. Menkes is copper deficiency, ATP7A. There is another disease called Wilson. Wilson is ATP7 beta, which is usually accumulation, too much. So too much is B, too little is A. Menkes is A deficiency. Okay. So Wilson is ATP7B. That's accumulation. Accumulation on the liver, hepatitis, in the brain, neuropsychiatric symptoms, in the eye, Kaiser-Fleischer. But copper deficiency will be Menkes, which is usually ATP7A, not B. Okay. Pretty good. Now, let's answer some questions, guys, on Synapse, and then we will finish in 5 minutes, okay? Just to see how can the nbme's questions look like, okay? And again, let's see here. So I prepared a few questions from the nutrition section. Let's discuss them. A woman come to you because of 6 months history of persistent facial skin lesions. She reports that she has been using an over-the-counter salicylic acid wash and benzoyl peroxide twice daily without significant improvement. She is otherwise healthy and taking no medication. Physical exam shows opened and closed comedones, erythematous papules and pustules, and the physician prescribed a topical cream containing tretinoin to be applied once. Which of the following best describes the cellular mechanism of action of this medication? What do you guys think here? Yeah. What do you think, guys? Goda, Imelda. Where would vitamin A happen or work? Very good, guys. Very good. It will work on the nucleus itself. Okay. And that's why it will bind to the nucleus receptors. Because remember, we said it's a fat soluble that go into the nucleus and work, not the cytoplasm and then the nucleus right away. Okay. So it will here will bind to the nuclear receptor. Okay. Uh, so that's very important. Again, when you discuss any QBank with yourself, guys, I want you to always try to study not only the answer choices, not only the explanation, but also the answer choices. Okay, and also the bottom line. So try to study it in details. Now that's here our QBank Synapse. I posted the link on the chat. You can try 40 questions if you want for free. It has like the most high yield 1350 questions. So if you are either short or of time or you need more practice, I believe it would be enough to pass the exam with using the NBMEs and getting over 70% of them. Um, it only contains the most high-yield questions, and I tried to review it myself. Me and Dr. Asad review each question from the ones our authors have made, and I was adding questions um, myself intentionally. And of course, it has AI chat and the tutor support. We usually go into it every day. Okay, 1350 questions, and we will be making like more in the future. Okay, you can get free samples from the link I have posted. Thank you, Saturday. So Saturday said that he have subscribed to it and it's very good. Yes, it is. I rarely like when I advertise something, I usually believe on it. We worked on this QBank very much, and I was literally trying to, when I review any question, me and Dr. Asad, we try to remove any useless information and try to add the only high yield stuff. The step two QBank, we are still building on it. It will be finished within 2 months, Mitchell. There will also be something called tier two. So we will add few other questions just in case you take the NBME and you feel like you need more practice. We will add tier two in the future. But right now, it only contains what you actually want to know. Okay. Thank you, Chad. So let's see here. Another one. A 54-year-old man comes to the physician for a follow-up exam regarding hypertriglyceridemia. Okay. He has a history of gout. His current medications include lisinopril and fenofibrate. He has a body mass index of 29. As part of nutritional assessment, the patient complete detailed 24-hour diet recalls and the analysis of intake is the following. Protein is 100, carbohydrate is 200, fat is 50, and ethanol is 50. So I will answer it, guys. I will not calculate it, but I will answer it here. So the way to answer it is that protein, each gram is 4 calories. Carbohydrates, each gram is 4 calories. Fat, each gram is 9 calories. Ethanol is 7 calories. Okay. So what we will do is that this 100, we will multiply it by 4. We have 400. Then the 200 by 4, we have 800 calories here. The 50 by 9, I don't know what we will have. Is it 250? I believe. No, I don't even know how to calculate. Oh, 450. Okay. And this 50 by 7, which is like this. So we will combine all of them together. Here we have 800, 800, 160, 2,000, right? That's 2,000. So the fall here is 2,000. That's an important question they usually ask on the nutrition. How to calculate the calories. I know it feels dumb, but that's usually what they will ask about. So the protein, the carb, the fat, and the ethanol itself. Okay. Now, let's go on to another question. A person has rash that appeared after a week-long family camping trip. The parents note that the rash is confined to his face, neck, and the back of his hands. The patient diet is varied, includes meat, dairy, and vegetables. Physical exam shows plaques in sun exposed area. He's having dermatitis. Tryptophan in the urine is high, valine is high, isoleucine is high, phenylalanine is high, arginine and lysine are normal. So, which of the following pathophysiological is most likely responsible for this patient condition? What do you think here, guys? Which vitamin is the one that will cause diarrhea, dementia, dermatitis, and is the one that will get deficient if you cannot absorb tryptophan and the other amino acids. And what's this disease, guys? If you can't absorb amino acids. So that's the thing. Uh, Heart nerve disease. Okay. Now, what type of amino acids are tryptophan? Do you remember? Are they basic or acidic or neutral? If you remember. Amazing. Perfect. They are neutral amino acids. There is problem absorbing neutral amino acids in the urine. So the answer here, guys, will be impaired intestinal and renal transport of neutral amino acids. Okay. How about A? Absorption of basic amino acids. That's the cola amino acids, the arginine, lysine, cysteine. And this absorption of cola problem can cause usually kidney stones, cysteine kidney stones, okay, which are hexagonal in shape. So here's that cysteine. How about C? Inadequate intake of niacin? No, no, this person is taking meat, dairy, vegetables. He is not taking corns. So he is taking adequate intake. The problem is that he can't absorb tryptophan in the urine, so he can't make niacin. Okay, so there is adequate. Reduce the activity of branched chain. Guys, branched chain amino acid dehydrogenase is important to metabolize the valine leucine isoleucine. And this is important in maple syrup. How do I diagnose maple syrup? Burnt sugar in the urine. Burnt sugar. There is no burnt sugar in smell. Burnt sugar smell in the urine. So wrong. Okay. Wrong. Reduce the conversion of phenylalanine to tyrosine. That's phenylketonuria, which will usually cause albinism and the musty body odor. Phenylketonuria. Albinism, eczema, musty body odor. So this is wrong. So here, that's impaired absorption itself. Okay, that's an impaired absorption itself. Okay. Yes, I usually do Dinese. I usually do. Also, Dinese, because Dinese is subscribed to the QBank. Whenever you have like any feedback, you can choose it here, and the feedback will reach directly to me and the support team. From this one, I click 2 times. If you know, like, if you mean the elimination one, right? I click 2 times, and then it gets eliminated. Okay. In the real exam, it's the same thing. In the real exam, it's the same thing. And we have here the theme, like you can change the theme, and you can make it similar to the uworld, to the nbme itself. So it can be similar to the nbmes. Okay. Now, let's do this one. A 14-month-old dark-skinned boy is brought to the physician by his parents for a routine wellness exam. The parents are concerned that hasn't. This is the new uworld outring, okay? That he is not yet walking independently and that his legs appears curved. The patient has been exclusively breastfed since birth, and he hasn't yet been introduced to solid food. Physical exam shows a prominent forehead and widening of the wrist. There is significant bilateral outward bowing of the femoral and tibia. Now, which of the following pathological process is most likely responsible for this patient? What do you think? Amazing. Perfect, guys. Perfect. So this person is having decrease in both of them, calcium and the phosphorus. He is young. Can you see dark skinned? Why? If you are dark skinned, you protect yourself from ultraviolet rays, so you can't activate vitamin D. Can you see? Okay. And he has been exclusively breastfed also. That's another risk factor. So that's vitamin D. Vitamin D is important for calcium and phosphorus, which are minerals. So there is defective mineralization. Okay. Decrease the proliferation of chondrocytes. That's achondroplegia. Yes, so say. Which usually a person with large head and short stature. Large head, short stature. Achondrochondrocytes. Impair the hydroxylation of proline and lysine. What is this? Huh? Impair the hydroxylation of proline and lysine. Very good. Amazing. So answer choice C for vitamin C deficiency. Vitamin C deficiency. Very good. Okay. Failure of osteoclast-mediated bone resorption. What do you think? Is this? If you cannot resorb bone, you can't break down bone, you will have too much bone. So you will have the opposite of osteoporosis, osteopetrosis, too much bone. osteopetrosis. Okay. Disorganized mosaic pattern of lamellar bone, that's a Paget disease. It happens in all the people and it increases alk-phos. Paget disease. Very good. Okay. Why the alk-phos here is increased? Because the bone is trying to overcome the problem in mineralization, so it's activating too much osteoblasts. And this activation of osteoblasts can increase the alk-phos. Okay. So here it's defective mineralization of the osteoid matrix, guys. That's very important, and that's rickets. Okay. Again, I want you, whenever you review question, read the answer choices very well, read the explanation, read the everything, read the high yield tables to differentiate rickets from osteoporosis, from Paget disease, everything. Because I myself, guys, again, I added this high yield tables myself and was reviewing it. And after this, if you don't know the answer, usually use AI chat, either like in uworld, ChatGPT, or Synapse. And then we have the tutor support every day for 1 hour. Okay. Now, that's most of it. If you need more explanation of this topic or any other topic, you can try me or any of our amazing tutors. I can make a specific plans for you. This is a plan for one of my students. Okay. We can go through your nbme's mistakes. We can increase the scores that you got. We had too many successful scores and too many students passing from using like either the tutoring program, the crash course, or the QBank. And it depends usually on which one you would love to do, but hopefully it would be worth your while, guys. And again, there is always refund the policy free. You can refund the crash course after the first day. You can also change the tutors however you want, and that's most of it. So let me first, before I move, guys, because I wanted to make this webinar every like Saturday, very good like this. So what I want to do is that I will post with you the Telegram group. We just made it right now, so you can join it. So I can like inform you about any webinar we will have and about the topics that we will be going to discuss. Okay. This is here is literally everything you would like to do. Literally anything you would like to do in you would like to know in the nutrition. Probably you would need to repeat it again near your exam, especially at the last 3 days of your exam. At the last few days, I want you to review the free 120 and to repeat this specific webinar. Okay, so that's it. Thank you guys so much. Okay, I really appreciate it. I will be sending the PowerPoint, both the annotated and the non-annotated, in the YouTube itself channel. Okay, so thank you so much. And again, please join the Telegram group so I can post and we can talk about anything you want. I will probably be there. Okay. Thank you so much. Okay. Yes, I would actually recommend this, Ramin. Even especially if you want something very short to finish your to finish it and go into the exam, but combine it with the nbme's. I would recommend doing Synapse itself. Okay. Thank you. Thank you, Rodina. And happy Eid. Bye bye, guys. Bye bye.